lovely message, Sensei. Thank you very much. Without further delay, I would like to introduce today's my honorable guest, Honorable Asha Seth, the first Indo-Canadian female. Today's my honorable guest. It's okay, microphone? Okay. So the Honorable Asha Seth, Chair of Seth Foundation for Health and Human Welfare, Honorary Patron of MIH, the University of British Columbia, Canada, and Patron of the Canadian Council of the Blind. She's a physician in obstetrics and gynecology in family practice and a member of the Canadian Medical Association. Dr. Asha Seth served in multiple Senate standing committees and Aboriginal Social Affairs, Science and Technology, National Finance, Internal Economy, Budget Administration. She is a Council Award recipient from the College of Physicians and Surgeons of Ontario, Canada, and the Peace Dreamer Award recipient in 2014 from the Sri Chinmoy Foundation of Canada, awarded to politicians and diplomats for their service to the country of the world. She is also internationally trained physician and also senator, politician, and we would like to introduce today our Honorable Asha Seth. And I would like to have my team to share Asha Seth's message for our participants. Thank you.
Hello, everyone. Thank you for giving me the opportunity to speak on nutrition. I'd like to say thank you to Dr. Shafi, who has been very kind, has invited me to speak on this subject, maternal, newborn, and child health issues, especially on nutrition. So here I start my story. As a woman and mother, I pursued my career as a physician, delivered thousands of babies and helped bring life into the world, heard the first cry of baby and laughter of the family. What an incredible experience I had. I embraced maternal and child health as one of my main causes. After a lifetime of services to my community as a physician, being a senator, I was determined to support women and children around the world by giving them an international platform. So I continued to represent Canada's #1 development priority through my professional and philanthropic work in maternal, newborn, and child health by collaborating with civil society organizations to advance the reach of these efforts in places with the goal of eliminating preventable deaths in mothers and children, especially in vulnerable populations. So in the Senate, I introduced the second week of May as an International Newborn Child Health Week with the goal of engaging Canadians on the health issue affecting mothers, newborns, and children in Canada and around the world, reducing maternal and infant mortality, improving the health of mothers and children in the world's poorest countries, promoting equal access to care to women and children living households of lower socioeconomic status, those with the lower level of education, those who are newcomers, and those groups who live in a remote and sparsely populated area of Canada, and preventing thousands of mothers and children from unnecessarily dying from preventable illness or lack of adequate health care during pregnancy, childhood, childbirth, and infancy. So on November 27, 2014, I passed a Senate motion establishing International Maternal, Newborn, and Child Health Week, which takes place annually during the second week of May. And this awareness opportunity provides a yearly platform to engage citizens and international partners on the health issues affecting mothers, newborns, and children in Canada and around the world. So it was extraordinary to see then how International Maternal, Newborn and Child Health Week received support from all levels of government as well as Canadians. So nutrition in maternal, newborn and child health care is very important indeed. So here, in fact, the 13th International Conference on the Maternal and Child Health Handbook, which really promotes health equity and aim to bring the health as to mothers and their children to the forefront, as too often social barriers make mother feel invisible. So we all know basic physical development of children worldwide is being compromised. Many children do not receive the nourishment they need to develop properly. This leads, in fact, to both physical and mental health issues over time, which is often irreversible. So fact is that the first 1000 days of a child's life are the most important phase in its development. So this span the time from conception to a child's second birthday. If damage is done due to the malnutrition, it becomes irreversible. So nutrition has a vital impact on women, girls, and their communities for generations to come. And yet, 1 billion women and girls worldwide are held back by malnutrition. Malnutrition is, in fact, is both a symptom and a cause of gender inequality. Malnutrition limits the capacity of women and girls to grow, learn, earn, and lead. So gender discrimination too often relegate women to the lowest rungs of the economic and social ladder, making matters worse. In some societies, women and girls eat last and least. So nutrition is an investment the world must make in nurturing the youth of today through excellent nutrition to ensure a better world tomorrow. So, my friends, the primary objective of this conference is to advocate for social unity through equitable, holistic maternal and child care around the world. That all people have a right to food and good nutrition. It unites people from governments, civil society, the United Nations, donors, businesses, and researchers in a collective effort to improve nutrition. So malnutrition costs the global economy $3.5 trillion a year. Nutrition is one of the most cost-effective investments for a healthier, more productive, and more equitable world. So studies have shown that every dollar invested in nutrition yields $16. And I think that's a pretty good return on investment. So my friends, advocating for children is not a choice. It is an obligation. You just never know. Perhaps that's a child that you are able to advocate for or receive better nutrition becomes you lobbied your government representative, might become someone of prominence and not just a statistic. Do your part. Do your part, and the world will be a better place. Thank you. Thank you.
Thank you very much. Thank you very much, Senator, Honorable Senator Asha said. Yes, you are rightly mentioned that we have to do our all part, and that's why I could see 20 years ago, 22 years ago, our Professor Nakamura started to promote, advocate a maternal child health handbook and to utilize in the primary healthcare facilities in communities to improve our situation. And it is huge impact on the community because handbook has the provision to not only birth record, also whole history of the mother and the child, so that they are aware what need to be done, what food they should eat, what resources they should go in, and that would be a very good tool. Thank you very much for your time and share your exciting story. Now, I would like to introduce our Maternal Child Health Symposium chair, the person who is my friend, who is my mentor, who was assistant professor at Osaka University in my early career when I went to Japan. And she is the one who guided us through with the Nakamura Sensei's faculty, Human Sciences, Osaka University. She was so caring. She is my favorite mentor and friends, Dr. Chandabon Fosai, who is the former assistant professor at Osaka University. And she is a medical doctor with the Master of Human Science field, International Health from University of Tokyo, a doctor of philosophy in human sciences from Osaka University. She is a former assistant professor, as I mentioned, and she is working Ministry of Health, Laos. She served as a Deputy Director General, Hygiene and Health Promotion, Department of Health, Deputy Permanent Secretary, Cabinet, and Director of National Nutrition Center. As you can see, very important portfolio. She was a member of Southeast Asian Minister of Education, Regional Center for Food and Nutrition Governing Board. She worked as a consultant of the country coordinating mechanism of the Global Fund Against HIV and AIDS, tuberculosis, and malaria, WHO consultant on non-communicable diseases in Lao PDR, National Senior Advisor on Newborn and Child Health for USAID, Lao Maternal Child Health Nutrition Project in Lao PDR, in Program Appropriate Technology in Health, it means PATH. So without further delay, I would like to welcome, the podium is yours, Dr. Chandabon Fosai. Let's give a big applause for welcoming person. Thank you. Dr. Chandabon, you can start your.
Okay. Do you hear me?
Yes, perfect.
Okay. Okay. Warm greeting and very good evening from Lao People Democratic Republic. Thank you so much, Dr. Safi, for your very nice introduction to me. And it is my great honor to be a moderator and welcome excellencies, chair and vice chairs, guests, participants and audience around the world to the interesting session of the sharing country experience on expansion, evaluation, and sustainability of maternal and child handbook in the 13th MCS Handbook Conference virtually. And I am very pleased to introduce 6 brilliant speakers from different continents in this session. Dr. Syed Emdadun Haq from Bangladesh, and Dr. Uchishis Agaluno from Nigeria. I'm sorry if I mispronounce your name. And Dr. Rami Mamau Habash from United Nations Relief for Work Agency for Palestine Refugee in the Near East. Dr. Susan Saliman Abu Sharia from Palestine. Dr. Lourdes Herrera Khalidu from Peru. And Dr. Muhammad Salim Bahaduri from Afghanistan. So may I introduce Dr. Syed Emdadun Haq as the first speaker. Dr. Haq is country representative Chicago Research Bangladesh in Bangladesh, and the director of the University of Tokyo Bangladesh office. So actually, Dr. Haq is my alumni from the University of Tokyo, where she got Master of Health Science and the PhD of Global Health there. And he also completed the postdoctoral fellow from the United Nations University International Institute of Global Health, Malaysia, and from the University of Chicago, USA. Dr. Haq is a global health researcher for over 20 years. And he also provides the training to Bangladesh researcher. He leads nearly 10 projects as a principal investigator. He has vast knowledge on the field research for intervention study and random control trials. He has successfully administered more than 20 projects and published nearly 40 articles in the peer-reviewed journal. Dr. Haq is going to present his research findings on maternal and child health to improve maternal and child health in rural Bangladesh. Dr. Haq's floor is yours. Please.
Thank you very much for nice introduction, my senpai. Yeah, it's very nice to see all of you in person, not in person, but in online. But thanks to everybody. I am from now. I am in Bangladesh. So good evening from Bangladesh. That's same as good morning in Canada. So I would like to go directly to my presentation. Yeah. Can you hear me, please? It's okay?
Yes. Yes.
Okay. Thank you very much. This is one of our study that many of you know that MCS handbook was piloted in 2002 and 3 under the leadership of Nakamura Sensei and Dr. Shafi Bhuiya in Bangladesh. So they did a very good job when like maternal health and child health was a very big concern in Bangladesh. So that was like big initiative by them. So after that, after 15 years, in 2016, we started a project that was in like maternal and child health handbook to improving continuum of maternal and child care in rural Bangladesh. It was a clinical trial, randomized control trial. So that is the initiative by like Dr. Shafi Bhuiya and Nakamura Sensei, and they published this JICA report also And that time they focus on like women's knowledge about the maternal issue. That time the education rate also was in Bangladesh not that high as same as like now. So that time that was like only for like piloting, focusing on understanding health education function, field usefulness of this maternal and child health handbook, and they can decode and bring, and during the antenatal care they can also show in the primary healthcare setup, so they can keep in this record. All these things was like introduced during that time. After a quite long time, then even like in 2016, 15 and 16, we started to introduce this handbook to our community people, and we designed a randomized control trial. So, you know, like Bangladesh almost like achieved like MDGs. After the MDGs, there was a target like MMR, like 70 per 100,000 population. So as I mentioned before, like during this pilot study of MCS handbook, they showed positively mother's knowledge, practices, record keeping, and service until their empowerment. So all that was happened. Based on that, then we designed this trial to evaluate the effectiveness of maternal child health handbook and enhance mobile tools. You know, that is very important. Like even in the rural people in Bangladesh now, they can use the mobile phone. So if we can provide like some education in addition to the handbook through the mobile phone, that will create some different changes that we have found in our study. So we designed this randomized trial, and we conducted the study among 3,000 mothers. It was in 3 arms. In the arm 1, it was like MCS handbook and mobile health education, and the second arm it was like only the handbook, and third one it was a control group. So you can see here like we allocated the information, as I mentioned before, like handbook and mobile health education, then only handbook and control group. So we conducted this study in 2 divisions in Bangladesh, Khulna division and the Dhaka division. So then we carefully, our field staff, they frequently visited during the pregnancy, from the pregnancy, then we diagnosed, and we had a good communication with the primary healthcare setup. So the pregnant woman easily, they can take the care from the primary healthcare setup. So it was a very good regular monitoring. Every 15 days, our staffs monitor the activities, and we take care every of the pregnant women. And we successfully completed that study. And that was the outcome. Like we have found like intervention arm and other control group. In the control group, you can see here like 34, about 35% in the control group. And whereas the intervention arm 1, it was like around 27.8. and 28 also in the intervention arm group. You can see here, we recorded all the antenatal care. We also recorded all the antenatal care who took the 4 times, as well as facility delivery. We also recorded all this information, how many times they received the facility delivery supports and knowledge and primary healthcare support. All the record we kept in every month through a community health workers visit. It was a very designed and a standard study. We can summarize the results here. You can see like compare the control group, those who are using like MCS handbook with the mobile phone, they are highly like mostly successful. You can see here 13.3% just progresses. In the same case as postnatal care also, those who are receiving MCS handbook and mobile phone, those group are like more likely to get more information and other keeping. And community mother, they are very lucky and they are very happy to keep this. And we just shared our story, like you can keep in for your daughter. Even when we during the follow-up, we also seeking the information that we found like the not only using by mother, it also keeping for their children in the future. That was very good success of the project. And that was our information was reported by the JICA in issue as a technical brief in December 2020. So based on findings, we can conclude that MCS with a mobile platform, as a lot of people are using the technology. So technology-based mobile MCS handbook could be a very good option to control them. As well as in the same time, we also can use such a tool for the primary healthcare setting for any other diseases. That is the recommendation from our side. As well as this local health system, the such a handbook that will help healthcare professionals to referral at a upazila level, at community level also. So that is all from based on our results. Thank you very much.
Thank you very much, Dr. Han. Thank you for showing the evidence base. Thank you for your informative presentation. I think this evidence base from your finding will be powerful to other countries who has not initiated and to those countries who already initiate of the MCS for expansion. So thank you indeed.
Thank you.
And may I move to the next speaker? The next speaker is Dr. Ukeshi Akalonu, Deputy Director of the National Primary Healthcare Department Development Agency in Nigeria. Dr. Ukeshi is a public health nutritionist. She is a member of the Nutrition Society of Nigeria, the member of the National Committee on Food and Nutrition, and National Councils on Nutrition, and National Councils for Women Society Nigeria, and Federation of African Nutrition Society Congress. Dr. Ukeshi served as a focal point, a focal person in the UNICEF-sponsored pilot of patient health smart card for tracking and referral new case children with the severe acute malnutrition. And using a customized Vitira Health mobile application. Here, Dr. Ukeshi is going to present the development of maternal and child handbook in Nigeria. Dr. Ukeshi, floor is yours, please.
Thank you, Ma. Her Imperial Highness, the Crown Princess Akishino of Japan, the father of MCH Handbook, Professor Nakamura, the pioneer student, so to speak, of MCH Handbook, Dr. Shafi, the chair, my teacher and mentor, Akemi Bando, distinguished participants on this call, good morning, good afternoon, good evening. I am Dr. Ogechi Akalonu. I work with National Primary Healthcare Development Agency under the leadership of a dynamic leader, Dr. Faisal Shuaib, who is very, very keen in upgrading the single separate MCH cards to National Integrated Mother and Child Health Handbook. So my presentation, I'm going to tell us the updates of the development of MCH Handbook in Nigeria. Next slide. So the presentation outline will go this way. Next slide. Like I told us, NPHCDA is that dynamic organization, a parastatal of the Federal Ministry of Health, mandated to make Nigerians healthy. We empower Nigerian communities to achieve better health. We promote widespread access to quality health care for all Nigerians. We improve effectiveness of primary health care delivery across Nigeria. And we do this to fulfill the following 7 corporate goals: control of preventable diseases like immunization. COVID vaccination is ongoing nationwide as I speak. We improve access to basic healthcare services. We improve quality of care. We strengthen institutions. We develop high-performing workforce. We strengthen partnership, just like what we are doing today is a good partnership. And we also strengthen community engagement. I will tell us further as we go, because yesterday, my mother, Professor Mariam of Kenya, appealed for global strengthening of community health workers. And I can tell us that Nigeria, through my organization, National Primary Healthcare Development Agency, has transitioned community structure, the community health workers, the chiefs, the mentor mothers, into what we call community health influencers, promoters, and services. They are the community health workers rebranded. They are the community people, trained community people, nominated by the World Development Committee to ensure that they refer a client, do follow up, they have first aid, they ensure that pregnant women go to the health facility to access care. They create awareness and create demand and ensure that people improve their health-seeking behavior at the community level. Next slide. So why are we upgrading the PAC cards? Like I told us, our ED came on board and noticed that we have several single PAC cards, from different organizations, different NGOs, different development partners, all over PACs. And we started discussing, he started discussing with us that there is need to follow the trend, to move on, to make clients more visible. Because what we see at the health facilities sometimes is not appropriate. The health workers, some of them are not well trained. Some underutilize the PAC cards. Some of them have poor paper quality. They can't even plot the growth chart because of the poor graphing techniques and a whole lot of issues. Some messages are not appropriate. Next slide. So this is the example of the single separate PAC cards. And this is, I'm proudly to show us, please, can you go back to I'm proudly to show us heritage. By the time the card is out, this is the kind of picture you'll be seeing. Typical Nigerian women from different backgrounds. Next slide. So what is the objective? The goal is to update the current single separate PAC cards to National Integrated Mother and Child Health Handbook, to improve the integration of mother and child health services at the health facility and at the community level, to improve the content, design, and durability, to improve the continuum of care, to improve ownership, make it more involving, because it's not also talking to people that have a health issue, but the well people can also benefit because it has some educational and informational materials that can benefit life. Next slide. So what have we done so far? Luckily, UNICEF has procured a consultant. The name of the consultant is Think Place Senegal. We have had our inception meeting on Tuesday, the 23rd of August. We have started designing the roadmap, the framework on how we are going to go, designing the handbook, talking about the field test, talking about the printing, and then coming back, the lesson learned from the field test, validate it, print the final copy, roll it out, and then distribute and monitor the process, monitor accessibility and the utilization. So our partners, our natural key partner is UNICEF. We have a lot of partners, so many to put in here, but the lead partner is UNICEF. I'm also happy to tell us we have in our midst Her Excellency, the wife of the former Kwara State governor in Nigeria, the wife of the former Senate president in Nigeria. I'm talking this because the handbook will need, at the end of the day, will need a political will, to make it thrive. So in 2009, she developed this book. And I'm happy to tell us that I was one of the facilitators that trained health workers on this in 2011, 2012. However, MPSCDA, my organization, remain that organization mandated to facilitate implementation of primary healthcare activities in Nigeria. So the responsibility, placement of home-based record is that of MPSCDA. So what international NGOs, local NGOs, development partners, and other stakeholders need to do is to support National Primary Healthcare Agency to roll out this document. And what about the resources? We are going to source resources nationally and internationally. UNICEF has committed, but UNICEF cannot do everything. We have all these partners here that are also willing, that have shown interest to support us. Next slide. So talking about implementation, we have started. We have developed the zero draft. I'm also happy to tell us that during the 3-day development of the zero draft, my teacher, my mentor, Mrs. Akemi Bando, she was with us. She participated actively throughout the 3-day duration. And we have started discussion. We have commenced the inception meeting. We have commenced the implementation of MCH handbook in Nigeria. So what do we hope to see? Before this, we had a desk review of other countries, and we also informally discussed with health workers, people, and they say, wow, it's going to be good, going to be beautiful, having a national integrated mother and child health handbook. That is going to save time, it's going to improve continuum of care, and the mothers who cherish it, they want to own it. Is actually convenient for the mother because she likes it. It has pictures and illustrations with practical designs, and is durable, and it's easy to lose the single card, unlike the handbook. So it's going to be user-friendly with a lot of key health promotion activities. And that's also going to be the community component aspect of it. Like I told us, we have CHIPS agents. These are trained community people, community volunteers that go house to house to encourage people, especially pregnant women and mothers of children under 5 years, to continue to go to the health facility. So there's a component of CHIPS platform in the handbook. And we also going forward, it will have a
Sorry, Dr. Ukeshi, could you wrap up about challenge and conclusion? Because
next slide, please.
Yeah.
I'm excited, I have a lot to say. So the challenges we faced before was the COVID pandemic, the security issues, which is getting better. Like I told us, we are mass vaccinating Nigerians now with COVID vaccination, and then the security issues, government is on top of it and is getting better. So the gaps is also the funding. We know that UNICEF cannot do it alone. Wellbeing Foundation, JICA, all the partners I mentioned before cannot do it. So we also need this committee, the International Committee of MSCH Handbook, to also support Nigeria in these very important projects. Next slide. So this is the images captured during the development of the Zero Draft Handbook. You can see a lot of participants there and the online participants like Mrs. Akemi Bandu. And of course, discussion continues. We have done our inception meeting. We have started planning, doing a work plan, the framework and all that. Going to the field, identifying enumerators, designing checklists and the questionnaire. So we are good to go. Next slide. Thank you very much.
Thank you very much, Dr. Ukechi, for a great presentation. I think that the initiative already done, and you show us about how hard and how difficult to initiate. But with our partnership and political will, that would not be happen. So that highlight is partnership and political will and patience. So thank you very much indeed. And the next speaker, may I invite Dr. Rami Mamau Habash, who is currently work with the UNRWA. And Dr. Habash is a public health specialist who have worked in the national, international, and NGOs in Palestine, the Saudi Ministry of Health. Dr. Habash has experiences in assessment, supervision, monitoring, evaluation, health policy, and responsible for improvement of the quality health services through institution capacity building in the field of maternal, child health, nutrition, school health, and he also has expertise on epidemiology for communicable disease and non-communicable disease as well. Dr. Habash is going to present how digital maternal and child health handbook work in UNWRA. Dr. Habash, floor is yours. Please.
Thank you for your introduction. And I want to say at the beginning, good morning, good evening, and maybe good night for our participants. And I hope that there will be benefit from our presentation, that our experience to provide the electronic application to be used by our beneficiaries in the region. Next slide, please. Our work in UNRWA, our work in UNRWA started by 1949 as a mandate by United Nations General Assembly. And our services cover Palestinian refugees in 5 locations. It is in Gaza, West Bank, Jordan, Syria, and Lebanon. We have there about 141 health care centers, and to provide our services for 5.7 million Palestinian refugees. Of them, we have annually around 87,000 pregnant women who provide for them antenatal care and postnatal care. In addition, we have around 425,000 child below 5 years old. Next slide. So our application, it has come to be used and to be easily used by our beneficiaries, as smartphones are becoming part of our daily life, and it helps improve communication between our beneficiaries and our healthcare provider. Especially we have names of all healthcare centers and how to contact them, and we have types of query to send the question and having answer. And we used this application during COVID pandemic and the lockdown and decreased services provided for pregnant women and children by sending regular information and make announcement about our telemedicine approach, and this facilitate better communication with our beneficiaries, and we are working now with our stockholders to increase this experience and to improve it. Next slide. So we have in our care center, previous last year, we have to provide two handbooks. We have the handbook and we have the application. And this application is developed by UNRWA and supported by JICA. It is the same as the handbook that used and printed and provided to our beneficiaries, but it has become easy to use by them once it is started to public use and download since April 2017. Next slide. And here we can see by time that there are increased number of users for this application by time, and even by fields that we are working on. And I will come later on why there are big differences between some fields and other fields, and it will be within the challenges we have to overcome and substitute the use of application by time. Next slide, please. And this is also another graphic showing that how we have some gaps between some field and other, and it is related more on the capacity of the Pakistan refugees that we have there. Next slide. So from right, left to right, so it is easy to be downloaded by Apple or Google Play application stores, and once it is downloaded, it is also easy to register, and pregnant women have to enter some information about the field, about the name of her center she is going to, and the registration number, and to enter her password to keep it secure to be used only by her. And after she registers for the first time, then it will be easy to log in from any application it is already downloaded. So it is easy to use. For the next time she wants to use it, only to enter registration number and password and enter. Next. Yeah, and we have reading a way to how to use this application. On the same time, there are video, and because of shortage of the time, I will not show the video, but it is very detailed and very informative for the user how to use, how to download, how to reuse, and how to use every manifestation within this application. This slide. So to support our beneficiaries to use this application, we work at our health center to have special Wi-Fi and to allocate some of our staff to support our beneficiaries, especially pregnant women, to download the application and train them on the future of the application, how to use it, how to check for their data, how to be sure that how to open health education materials, and this way we are supporting use of this application by beneficiaries. Next slide. And mainly it have 5 main features. It is part it is for mother, and another one is for children. And then there are a page for appointment, and another one for health education. And lastly, we have another page for treatment. Next slide. For pregnant women, also as you see, we have multiple issues related to antenatal care and women health. So we have a few about women recurrent situation visit during pregnancy antenatal care, during postnatal, and if she have any use of family planning, and the lab results, they can have it, and if there are any appointment by our health center, and if there are any treatment or any health education issue. Next slide. It is same for the children, and if the pregnant women have multiple child within the application within the health center, so it is easy for them to check by their picture of their name, and then another page will open for the choose child, and if they are choosing, for instance, to check for their growth monitoring, then we will have another page to show what type of growth monitoring you want to see. And once click on, for instance, the height, we will have a chart showing this information. And we believe by using application the chart, for instance, for the children, it will be more accurate as the data will be entered electronically. So there's no spot ever once it is entered by hand compared with electronic data. Next slide. And also we have an appointment, and this appointment page, it is have mother can check before appointment if she or her children have any appointment. On the same time, the application sends notification for the mother about if there are any appointment for her or for any of her children. And this appointment method working even if it is offline, that means it does not have to be connected all the time with internet. Next slide. And this is, we have 2 separate pages about health awareness, one for the children and another for pregnant women. This to allow not to be confused and mixing between messages during the reading that have to be given to the child or given to the mother. As I mentioned, we have notification method. We have 3 types of notification or interaction. We have messages that have sent according to the specific duration of the pregnancy or the age of the child. There are specific messages sent electronically by our filter to the mother to provide more health education material. We have second one to notification if there are any appointment need to and reminder for the appointment. and also for medication to not take medication, especially for supplement to prevent iron deficiency. And lastly, we start to have a quiz question and answer. So pregnant women can or the user can send any query related to the health of the pregnant woman or the health of the child, and we will send an answer for about it. Next slide. The main challenges, before to start the challenges, the main issue is that this application it is connected by our EMR at our health center. So any data entered to the pregnant woman maternal file or to the child growth monitoring or development chart, it will be reflected directly on this application. And this will support later on also and decrease time used by beneficiaries at health center. For instance, there is no need for pregnant woman to stay till she has the result of her examination, lab examination. She can go back home at the application once the data is reflected on our EMR and her EMR file. It will be also seen by her application. And this application, we thought that it will be decrease the cost of printing materials. One, it is become used by the community and have more acceptance. And also it could be a supportive way because to support having the medical file or the booklet all the time, because woman or any user can forget to take the handbooks everywhere, and it is not used to be taken only if they are visiting to healthcare centers.
Sorry to interrupt you. Please conclude because
I have one.
Yeah.
I will be fast. Okay, and can be used even if she left her handbook at home, but the smartphone would be with her. Unfortunately, the challenge is that not all the women have a smartphone or internet, or even a smartphone maybe don't have the capacity to hold this application. And not all of women are aware about this one. And also there are variations, as I mentioned, to support pregnant women to use the application. Next slide. And to overcome these issues, as I mentioned, we open fashion to support the women to download the application. And also we go to the community to promote use of this application to be widely used, not only by beneficiaries, but also by private or other healthcare providers. They can ask about the application and the data, medical data within the application, as they are looking to the handbook. And also by using more messages and more notifications, this will support the user to use the application. Thank you.
Thank you very much, Dr. Abbas, for your sharing great innovative of the digital MCS handbook. The application made available to the public and the App Store. That's amazing.
Yeah,
that's amazing. Yeah. So thank you very much. So next, I would like to invite Dr. Susan Suleiman Abu Sharia, who has been the director of Community Health Department, Ministry of Health Palestine since 2015, and a director of OBGY Department in Palestine Red Crescent Hospital, Ramallah, and Medical Center Gaza. Dr. Abu Sharia is a medical doctor in general medicine and gyneco-obstetric and Master of Public Health. She served as a director positions at Ministry of Health in many centers, including Communicable and Chronic Disease Center, Center for Medical Treatment and Rehabilitation Alternative of the Drug Addicts, and the Department of Medical Licensing. She has extensive experiences work at primary healthcare center in Palestine. Dr. Abu Sharia is going to present how expansion of maternal and child handbook in Palestine. Dr. Abu Sharia, floor is yours.
Thank you, ma'am. Assalamu alaikum. Good morning. Good evening, everyone. It's my pleasure to be with you today and to present my country. And I will explain the expansion of MCH handbook in Palestine. So the Palestinian population in Palestine, next slide, please. And next. The Palestinian population, it's around 5 million, 3 million in West Bank, 2 million in Gaza. And after using the MCH handbook, the infant mortality, it's reducing, but it's still stable. And the maternal mortality, it was reducing too, but after COVID-19, it's increasing now. Next slide, please. We start using MCH handbook in Palestine and Ministry of Health since 2005. And it was the first of its kind in Arabic and was developed by Palestinian Ministry and together with JICA, UNRWA, and UNICEF. In 2007, Ministry of Health made a national launching for MCH handbook. And since 2008, all public and UNRWA health facilities in Palestine using MCH handbook. And in 2009, the Ministry of Health decided to replace the old vaccination card to MCH handbook to be a national registration tool. Since that time until now, up to date, the MCH handbook is utilized in all public and UNRWA clinic and in all public and private hospital. In recent year, the Ministry of Education linked the MCH handbook to student file into vaccination card. Next, please.
Sorry to remind you, 8 minutes.
Okay, we can see the picture of launching and the picture of MCH handbook, and our target, all mother and children in Palestine receiving MCH handbook. Rationale of MCH handbook: aligning with the Sustainable Development Goals, supporting governmental commitment for universal health coverage, multiple MCH health care provides with need for sharing records. The MCH handbook is a powerful tool that addresses the sustainable development of health system through using the health records for referral, emergency, and regular follow-up, and health education for expected mother and learning her for planning birth, for outcome and maternal mortality, as well as infant mortality, which is a challenge in Palestine. Our goals: to increase the number of women and children who receive the productive maternal and child health service with a good and high quality service. Avoid any health complication for both mother and child. Support the early detection and early treatment. And provide education tool for parents as well as healthcare. Next, we can see the flow of expansion of MCH handbook since 2005 until 2019 with the pictures together, Ministry of Health and UNRWA. Next, please. We can find the pilot phase is starting in 2005 to 2006 in some clinics in West Bank and Gaza. In national phase, we can find since 2007 until 2008, all public and UNRWA clinic starting to use MCH handbook. In private, after the Ministry of Health in 2009 replaced the vaccine card to MCH handbook, all private and public hospitals use MCH handbook. And we're still working since 2009 to use the MCH handbook in a private clinic. Next, why we want to expand the MCH handbook in private clinic? Next. Because we have more than 20% of pregnant women who goes to private clinic and they didn't receive MCH handbook during antenatal care, but they will receive the MCH handbook in a house at a hospital during delivery. Next, please. Yes. This is from the annual report. We can see the difference between the live birth and the MCH handbook during antenatal care. It's a big challenge for us to in a private clinic. How to expand the MCH handbook in a private clinic? We start since 2019 to communicate with OBG, Pediatric and Medical Association Society to use MCH handbook in a private clinic, but we still for official agreement. And we prepare all guides, orientation, short training for health provider at private clinic. And we will make MCH handbook as a requirement in licensing private clinic. And Ministry of Health will produce ads through different social media platform to explain for the community about the important MCH handbook and to be carried by women until finish her antenatal care, delivery, postnatal care, and child. Recommendation: ensure health providers complete and following the MCH handbook in a proper way, and raising awareness about the importance of MCH handbook. Ensure better monitoring, follow-up, and proper utilization. Communicate with academic institute, university, and college to facilitate the integration of the MCH handbook, pre-service training for doctors, nurse, and midwife. What's the next step? What we will do, inshallah, next year, digitalization. The digitalization of MCH handbook to connect and to contact to digital patient record system in primary and secondary health facility for easy access and avoid duplication of data. And to integrate of any planned digital application and system related to MCH handbook with MCH record registry to avoid duplication in data. And that's it. Thank you.
Thank you very much, Dr.
Tausan.
Dr. Abu Sharia.
Yeah. Thank you.
Yes.
Thank you, ma'am.
Thank you very much for sharing the very interesting especially from the expansion of the MCH handbook through partnership with Health Professional Association. And I very like it for sustainability as well. You show for incorporate or integrated of MCH handbook in the pre-service training. So amazing. Yeah, thank you very much. I think that our audience may learn from you a lot. So the next speaker, may I introduce Associate Professor Dr. Lourdes Herrera Calido. Dr. Lourdes is actually my best friend and the former colleague in the Osaka University under supervision of Professor Yasuhide Nakamura for almost 20 years ago. And Dr. Lourdes is a Peruvian midwife, and she is an associate professor at the Otame University, Faculty of the Global Nursing, Osaka, Japan, where she devoted for over 20 years and conduct activity to support migrant health. Dr. Luke was a consultant for Japan program of Inter-American Development Bank, which led to introduction of maternal and child handbook to Dominican Republic. Here, Dr. Luke is going to present expansion, evaluation, and sustainability of MCH handbook in Latin America. So Dr. Luke, floor is yours, please. Dr. Luke?
Thank you, Dr. Chandabon. I think we
Yes.
should proceed for the next candidate. Yeah,
Okay.
she is out of network, so that's why we go proceed.
Okay.
Next candidate, please. Thank you.
Okay. So that is the uncertainty, right? Because of the challenge of virtual. Okay. So may I move to the speaker, Dr. Muhammad Salim Bahaduri, who is the MCH Handbook Project Manager with UNICEF Ministry of Health Afghanistan, and who is also MCH Handbook Senior Technical Advisor, JICA Ministry of Health. Dr. Bahaduri has experiences and ever worked in family planning in UNFPA Ministry of Health and in INGO. And he also experienced for the program and project manager in INGOs. And he is a member of Afghanistan Family Planning Goodness Association. He is medical teachers in Molana Medical Institute, and he also is a medical doctor in public ward, in pediatric ward in hospital in Kabul, Afghanistan. Here, Dr. Bahaduri is going to present the implementation of MCH handbook project in Afghanistan. Dr. Bahaduri, please. Dr. Bahaduri?
Okay, good. If not, so we have Dr. Lourdes already online, so it's no problem.
Oh, okay.
Go with Bahaduri if he's available. Yeah.
Dr. Bahaduri, are you there? Okay. So if not ready, so may I move to Dr. Luke? Dr.
You
Luke
can-
Herrera, are
You
you
can
there?
you can read Herrera's bios and then we can go with Herrera.
Okay.
Sorry, and we should streak about the 7-minute slot, so we will
Okay.
take longer. Thanks.
Thank you, Dr. Shafi. Dr. Luke, I already introduction, right, Dr. Luke? So see, are you ready? Please, Dr. Luke.
Yes, my apologies for the delay. I tried to share the screen and I haven't been able. I don't know if you can see my screen now.
Yes, yes. Yes, we do.
Okay, so please, thank you very much. It's a privilege to be with you tonight. Dr. Nakamura, Dr. Shafi, thank you very much for this honor and for asking me to present the situation of the expansion, evaluation, and sustainability of MCH handbooks in Latin America. My name is Lourdes Herrera, and thank you very much for your presentation, Chair Madam, my dear Dasan. And I'm going to talk about the Spanish-speaking countries because we have the example of Brazil in Latin America. Brazil also has a MCH handbook. So today I have for objective to provide an overview of the situation of MCH handbooks in Spanish-speaking countries in Latin America, and to give you some examples of the development of MCH handbooks and other handheld health records. We also have some challenges, and I want to talk about the possibilities of MCH handbooks in Spanish-speaking countries. To the right, you see the American continent. We have 19 in Spanish-speaking countries here in this continent. So first of all, I want to talk about Argentina. In Argentina, we have the only MCH handbook in the region. It's a national system. It integrates both mother and child information, and it has a legal background that reminds very much of the maternal and child health law in Japan. The official name in Spanish translates to Maternal Child and Teenager Health Handbook. It is compulsory to use this handbook by law since 1983. At first, it was targeting pregnant mothers and children under 14, but nowadays it targets children until they become 19 years old. Now, I want to give you some examples. First, we have the experience in Mexico. In Latin America, most programs that have developed an MCH handbook are related to JICA, have some roots in JICA. So this Mexican experience has roots in the JICA project between 1992 and 1997. It was extended for 1 more year in order to develop the handbook and expand it in Mexico. It started in 2 states in Mexico, Guerrero and Veracruz. The program finished, and unfortunately, the MCH handbook did not expand to the whole country. But what remained here is that from 2002, the country has introduced hand health records for children, teenagers, adolescents, and elderly people. Now we have a series of hand health records for all of these ages, for group ages. So the handbook in Mexico, as it's not integrated, we have a handbook on the left side, you see, for children 0 to 9 years old. It is very comprehensive. It has a lot of information, hand health records, it's immunization, it has educational tools, etc. And it's free of charge. It's a national system that everybody has the right to receive. Also, it has on the bottom, on the left side, on the bottom, you can see that there's some chart to for the users to see the baby stool and compare the normal and abnormal. It also has some educational pages about sex education, addictions, etc. On the other side, on the right side, you will see the pregnant women card. It's the perinatal card, and it talks about the risks for the pregnant mother, and it has a nutritional education and so on, but it's not together with the child card. Now let me move to the Caribbean and to talk about the Dominican Republic. As you know, the Dominican Republic shares an island in the Caribbean with Haiti. In the Dominican Republic, the Inter-American Development Bank had a program called the Japan Program, and they introduced the experience of the MCH handbook in the Dajabon province. I was assigned by Dr. Nakamura as a consultant for this project. And I may not be the mother, but maybe the auntie or the godmother of this handbook. And the pilot version was developed in 2003. And by 2006, it was updated and it was improved. And it extended to another provinces also. JICA took over the project, and from 2004 to 2009, in Samana province, they continued developing the MCH handbook. The MCH handbook was developed in Spanish for the Dominican Republic, and they immediately developed also a Creole version for the Haitian people, the people from Haiti that crossed over the borders to seek healthcare in the Dominican Republic. So the diversity was immediately taken into consideration. The cultural issues were taken into consideration in this handbook. Nowadays, this project is not going on anymore. To the best of my knowledge, now the country is using a national health system, a mother's handbook, the last version from 2012, and a separate child health handbook from 0 to 5 children. Now I will go back to the contents of the experience in Argentina. In Argentina, all the national system, they have a national handbook. The contents are similar for all the country, but the states, the provinces have autonomy to decide the contents in some cases. So there's a provincial system and a national system. It's free of charge. Mother and child health records are integrated together, and it covers children until 19 years old. So women are also trained to use this MCH handbook. There are some slight difference, and the appearance is different, coloring, etc. is different depending on the location. They have different contents, but basically they have information about metabolic disease screening, immunization, and so on. They have infant obesity prevention, addictions. They have some other information according to the needs of their population. For example, we have a high prevalence of Chagas disease in some trypanosomes in some places, and they give information about Chagas disease. So these are some of the Argentinian MCH handbook contents. It's interesting because this handbook includes parents' HIV status and also other serological tests status too. To continue to the south, the experience in Chile, again, hand health records, one for children and one for expectant mothers, for pregnant women. In Paraguay also, we find that handheld records have a roots in JICA project. A JICA project that started in 1995 and produced the Mother's Handbook. At the time, it was to support mothers who lived in the rural areas and do not speak Spanish. In Paraguay and in many other countries in Latin America, we speak two or more languages in each country. So in Paraguay, in the rural area, Guarani language is spoken. Again, in Paraguay also, so at the beginning, there was only the Mother's Health Handbook. Now they have the Children's Handbook and the Mother's Handbook, but separately. The experience in my own country, we have a national system. We have child health records and maternal perinatal health records, strongly influenced by the perinatal clinical records from the WHO. It's more than a handbook, it's a triptych folding card. Maternal and perinatal card, and it's compulsory to present for schools. It has records for immunization and so on. To the right of the slide, you will see an application. This is a hand health maternal health application, and it's very similar to the experience in Palestine. I was very surprised to see the contents. It includes the antenatal care, appointments, educational tools, and also they have units for alerting the mother who has missed some appointments or some clinical tests. Unfortunately, this is available only for it's a very large hospital. It's a hospital for the hospital users, for pregnant mothers who have a clinical history in this hospital. It's not a national system yet. But this is a large hospital. We have around 60 deliveries per day in this hospital. So just to summarize, MCH handbooks in Latin America have been established as national systems. So from with a top-down fashion, and almost half of the countries have MCH handbooks or other types of hand health records. But the idea of home-based hand health records has strongly rooted in Latin America. The presence of JICA and other agencies has been much influential, and they have been very good because the quality of the products, the quality of the handheld records that we have in Latin America, I can say it's very good. Unfortunately, to the best of my knowledge, we do not have any evaluation going on right now. So the use of the handheld records has been extended very much. And however, maybe a weak point that we need to work more on, to partner more maybe on, it's also their preference to have separate records, one for the mother and one for the child. And this, I think this is one of the biggest challenges that we have. The only country using MCH handbook integrated is Argentina, I repeat. Contents are appropriately updated, and we have also to consider for the future the cultural issues and the multilingualism that we have in Latin America. So that would be all for my report today. Thank you very much for your kind attention. And if there's any further contact for me, I'm sharing my address here. Thank you very much.
Thank you very much, Dr. Lourdes, and for very comprehensive presentation. We can see in your presentation almost many countries in Latin America implementation of MCS handbook. That's very great indeed. And may I back to the last but not least speaker, Dr. Muhammad Salim Bahaduri. Are you there?
So Dasan, just one reminder, Dr. Salim is trying hard. The internet is coming and going and dropping. So better not to stress too much. We are behind the schedule. So we ask if Dr. Bahadur is there, he can just speak, no need to on the camera because of internet connectivity. And I ask Dr. Bahaduri, please join without webcam. Try your best very briefly. Otherwise, we have your record.
Yes, can you see me?
Sure, go ahead.
Yes.
Yes.
Continue.
Can you hear me?
Yes,
Yes.
just continue.
Yes.
Yes, please.
Good morning, everyone. Can you hear me?
Yeah, we hear you. Please,
Oh,
please be short.
hello.
Because we very high behind. I'm afraid that he did not hear us.
Hello.
Yes, we are hearing you.
Hello.
Dr. Bahaduri, we are hearing you. No need to on your camera. Just continue speaking.
Okay. Okay. At first, let me thank from. Okay. Let me to thank for all organizer of this international conference, especially from Dr.
I think we lost him.
Yes.
Dr. Nida, can you just overview the slide? And Calvin, get ready. So summarize all these things, then it'd be better because we have all record for the viewer, for the participant, for your convenience. I am telling that we are going to share all the information in proceeding, so you will not miss anything. And this is the technical reason. So Dr. Bahaduri is not able to continue his speaking.
Yes, thank you, Dr. Shafi. So may I invite Dr. Calvin for the this discussion? Dr. Calvin, who is the member of International Committee on Maternal and Child Handbook and also worked in the MCS handbook for over decades. And he also now work in the as adjunct senior lecturer at the School of Health Science, University of Riku in Okinawa, Japan. And Doctor also have affiliated with the graduate program for health policy at the University of the Philippines, Manila. And he is very interested in disciplinary, including maternal child health, in indigenous public health and disaster preparedness, school health, community health. And he also founded board member of the International Committee on Maternal and Child Handbooks. And he has involved in many activity and project of JICA support. And Dr. Calvin's floor is yours.
Okay, thank you very much, Madam Moderator, my senpai, Shandavon Epoxy. It's all in the family, and it's nice to see everybody again here in the second day of the conference. Good morning, good afternoon, good evening. Here it's already good night in the Philippines. I am deeply honored to review and summarize the presentation of our esteemed colleagues on their experiences, implementation and researches on MCH handbook. MCH handbooks have been proven to be useful in promoting client, provider communication and information sharing to record health status, to raise health awareness, and to identify maternal and neonatal complications, and to encourage health-seeking behaviors in several countries worldwide. In the first presentation from Bangladesh by Dr. Haq, what they sought is to evaluate the effectiveness of maternal and child health handbook enhanced by mobile tools and to generate evidence informing the adoption of the program in Bangladesh. The study concluded, which indicated that the MCH handbook that enhanced by mobile platform has potential to serve as an essential part of the primary health care. And this is expected to scale up in rural Bangladesh for universal utilization of MCH. It is worth including that these tools in primary health care is needed or in order for us to achieve universal health coverage for mothers and babies in rural Bangladesh. Next was the presentation from Nigeria by Dr. Ogechi Okalonu from the National Primary Healthcare Development Agency. And they were able to update the development of the MCH handbook in their country. And at present, they were saying that the PHE card is not achieving its full potential. Single cards are used separately for mother and child, inappropriately used by clients and healthcare workers, and most times not legibly completed by health workers at the time of service. It is underutilized. And the goal is to update the current primary healthcare cards to National Integrated Mother and Child Health Handbook. And this aims to improve the integration of mother and child health services at the health facility and community levels, to improve the content, design, and durability, and to improve continuum of care and information management. Very promising. Though there are some challenges that she was able to raise, such as COVID-19 pandemic, security issues, time constraints, and fund logistics, there is a positive way forward of continuing dialogue with stakeholders, which she presented earlier. Next was the presentation from UNRWA by Dr. Habash, where smartphone apps like are also are beneficial in communicating and obtaining health and health service information necessary, especially when we talk about telemedicine and digital health. And they believe that this will become a backbone on primary health care and universal health care in post-pandemic era of COVID-19. And in the UNRWA, it requires multi-sectoral approach to realize such and to sustain digital health. It's quite interesting, that the mother-child healthcare application is composed of 4 modules for mothers, for children, for appointments, and alarming alerts. As well as similar to what Nigeria has been experiencing, there's a few challenges with this project. One, that mothers that don't own mobile phones and don't own smartphones may have some access issues, as well as those with internet connection issues, as well as some mother mobiles have no storage capacity. So this should be addressed not only technologically, but also for the mothers in order for us to ensure equity of access. And then we also have a very nice presentation from Palestine from Dr. Abu Sharia, which she presented how the MCH handbook was introduced in Palestine in 2005. And it aimed to, the target was actually the mothers and children in Palestine, in the Palestinian refugees in West Bank and Gaza. In 2021, the MCH handbook is utilized in all public and UNRWA clinics and in all public and private hospitals. They believe that the MCH handbook is a powerful tool that addresses the sustainable development of health systems through the use of health records for referrals, emergency, or regular follow-up of care and education of expectant mothers. There are some challenges, but their way forward is the digitalization of the MCH handbook to be connected to digital patient records in primary and secondary health facilities for easy access and to avoid duplication of the data. They also plan to integrate the systems to MCH, where MCHE records, to avoid duplication in data entry. And then finally, for today, we had the presentation coming from Dr. Lourdes Herrera Cadillo from Peru, where she was able to share the experiences in Latin America, specifically from Argentina, Mexico, Peru, Dominican Republic, Paraguay, some of the countries she mentioned. And it's quite interesting to take note that there are some challenges as well, no? That we learned even in Latin America on the systems established by the government, where it was first introduced by JICA, but sustainability remains an issue, and the reluctant use of the maternal and child health record, no? And as we have seen, only Argentina was using the MCH handbook identify, and the contents, no, and the quality should be appropriately adapted and adapted by regions. No stakeholder involvements and some cultural issues. It is quite unfortunate that we were not able to enjoy, no, the summary implementation of MCH handbook project in the public sector of Afghanistan. But as Dr. Shafi had mentioned, we will be having a copy later on. Anyway, I believe that we do to ensure a continuum of MCH care, maternal and child health handbooks can strengthen a continuum of care within the fields of maternal, neonatal, and child health. The MCH handbook is a book of all-in-one, what we have learned today. Information from many fields, such as immunization, infectious diseases, nutrition, coming from our speaker earlier, no? Family planning are all integrated into one book. And as mentioned, as highlighted by Dr. Lourdes earlier, we have to offer a flexible, it should be a flexible tool that can be adapted to each of the country's needs and culture. The MCH handbook is very flexible and user-friendly because it is easy to add some colors, illustration, figures, and even can be adopted into a digital MCH handbook. But I think one of the questions that we have to think about is that, are we promoting further, no? How should I say, gap when we think about digitalizing the MCH handbook, especially since that some of our presenters have already raised the point that some of the mothers may not have the smartphones, may not have the internet connection, because we believe that no one should be left behind. It is one philosophical foundation of the SDGs. And we know that the MCH handbook is recognized as a tool for improving the social inclusion of persons, refugees, migrants, of different ethnic minorities, minority backgrounds, the poor, or even those who are disabled. And with that, I finish my review and summary of the presentations for today. Thank you very much.
Thank you very much, Dr. Kavil. Before closing our session, I would like to gratitude and thanks to 6 brilliant presenters, although the last speaker has not been in here, but we learned a lot from that. And also I would like to thanks to the intelligence discussion, Dr. Kavin, who made the very perfect conclusion. So may we give the big applause to our 7th brilliant and intelligent speaker and discussants. So thank you very much. Over.
Thank you very much, Dr. Chandabon Dasan, for your excellent commentary, and then thank you, Kelvin, and our colleagues, even though some technological issues, but we have those from Dr. Salim. So we will share with all our audience. Thank you very much. Now, where we are now. So I would like to go to the next session. Is like if any question my team received from anybody. Is any questions we got? Okay, so our team is working to answer your question you have. So for the interest of time, is exactly 10:35 now. So over, but I would like to switch the gear because we have a stress and anxiety. We want everybody to listen 3 minutes different thing. Let's start Nida or Dr. Sanders to share with very briefly something different, then I will come back to you.
The therapeutic healing dance involves different body movements, different structures. It is very structured. So I'm going to do in a short time, just 3 different structures, of course, because it involves the body, mind, and soul. So any structure that you do, any movements that you do, has to be relevant to it. So the shoulders are involved, fingers are involved, your knees are involved, but as much as I can do in a short time. Please join me and enjoy.
I see trees of green, red roses too. I see them bloom for me and you. And I think to myself, what a wonderful world. Clouds of white, the bright blessed day, the dark sacred night, and I think to myself, what the colors of the rainbow, so pretty in the sky, are also on the faces of people going by. I see friends shaking hands, saying, how do you do? They're really saying, I love you.
அடியே அடியே என் குட்டி பட்டாசே, தனியே தனியே வந்து விட்டு வெலாசே, உயிரே உயிரே என்ன மன்னிச்சு பேசே, கண்ணால் தீ வீசாதடி. சரிகமப்பா தானி நான் சொல்லி தரவா, துடிக்கிற ஆசைய நான் கொட்டி விடவா, வருகிற ஆவணி நான் விட்டில் சொல்லவா, இடைவெளியே நீ வா, 2 முத்தம் வைக்கவா, மனக்கும் அஞ்சடி பர்ஃபியூம் நீ, மயக்கும் கண்ணுல கஞ்சானி, சிரிச்சா சிந்திடும் சிந்தேனி, முறைச்சா கீரிடும் கண்ணாடி, உடம்பா சக்கர பள்ளி நீ, வயசில் மின்னுற அள்ளி நீ, அருகில் பக்கமா வர வெக்கமா, அடி நில்லடி கண்ணம்மா சொல்லடி செல்லமா, உனக்குற முத்தம்மா, மனசில் என்ன சத்தம்மா, வெளிய அத சொல்லம்மா, உசுரில் எங்க யுத்தம், அடி தள்ளி நெஞ்ச கிள்ளி என்ன தள்ளி வைக்கலாமா, கொஞ்சம் சொல்லு உன்னை அள்ளி கொள்ள கிள்ளி போல துள்ளி வருவேன்.
Okay, so, yeah, so thank you very much for a wonderful try. Maybe our friends and colleagues who tried. So we have now 4:44, but we start at 4:45. Now I'd like to switch the mic, our friend, Dr. Anneke Kassler, who is the chair for good practices on MCH Handbook. And is an interesting session. We have a presenter from Japan and Thailand. And I would like to introduce our moderator, Dr. Anneke Kassler. Floor is yours.
Thank you, Dr. Shafi, and thank you for the introduction. I had a great dance, so I feel really refreshed.
Yes.
After all the great examples of this today from various countries, how they develop and implement and expand the MCH Handbook, we have now another exciting program waiting for you about good practices of MCH Handbook. And like Dr. Shafi already said, we have professionals from Thailand and Japan, and they will tell us about their views on additional digital or a special MCH Handbook, and also during the COVID-19 period. And I'm really glad to welcome Professor Tomohiko Tsukishita, who is professor and chair at the Department of International Affairs and Tropical Medicine at the Tokyo Women's Medical University in Japan. And he worked for a long time in Africa, and especially in Kenya, and he did some research also about the MCH Head services by mobile phone. And I'm really, I really like it to hear him to give the presentation. And Professor Tsukishita, I see you are here. The floor is yours, so please.
Oh, thank you very much. Yeah, Dr. Anneke, thank you very much. Dr. Shafi and Dr. Nakamura is having this great opportunity to present about the MCH Handbook and also the COVID-19. It reviews the importance and the significance of MCH Handbook. So just you can see my presentation here. So can you give me next slide? So I have been working in Japan. However, as Anneke told us, I'm working in Africa more than 25 years and still working online to support African countries to strengthen for health systems in their countries. So give me next, please. But COVID-19 pandemic hit the world's vulnerability, especially focus on the death cases by the continent. It shows Africa is still remaining the little affected by COVID-19. It was completely different from other pandemic in the past. Give me next one. Also, the case fatality rate is quite same among 6 continents in the world. It means Africa, where I have been working for, is not so higher than the others, although the healthcare system is so limited. Please give me next one. However, actually Africa is strong to pandemic, and also the mortalities and also cases are not so much. However, the problem is the shadow side of the pandemic, which affected especially gender disparities and also economic disparities, especially women's and small children affected much by COVID-19 indirectly, actually. Maybe give me next one. But those shadow side of pandemic have to be mitigated before the pandemic happens, because they're female are susceptible to the pandemic, and also they're strong in Africa by the COVID-19 pandemic. However, they are very susceptible to the health system's weakness due to the COVID-19 and the global hit to the developed countries. I'll give you next one. Also, those female workers is already accounted for more than 70% of the healthcare workers are really also affected by the COVID-19 because they are working in the front line to the COVID-19. That's why we have to think about how we have to mitigate those gaps, especially gender and economic gaps. Give me next one. Also increasing the number of the cesarean section in Nairobi due to delay of the antenatal care and other, or delay of the services due to lockdown and other things. Give me next one. Also, women is also to hesitate to having a child and also even marriage during the COVID-19 pandemic. Even it's happened in Africa and everywhere. That's why we have to define our vulnerability actually should be renewed because our old vulnerabilities goes to poverty and also rural and also gender or poor nutrition, poor educational status. But COVID-19 revealed the new vulnerability in our society, actually globalization, urbanization, also aging in cities, and also those prosperity is part of the weakness of the human beings. So we have to reconsider about our vulnerabilities due to COVID-19. But one of the good solution is digitization of the services, especially focused on the maternal and child health. But this is the use case. Also give me next one. So handbook in Kenya and the introduction of digitization of the MCH handbook in Kenya, because a lot of people using mobile phone in Kenya, especially using mobile phone as a money transfer uses and communication purpose. Now give me next one. That's why they are eager to use the mobile phone and also cellular phone and the smartphones for the transferring the money and the transferring the information and the communication. That's why we developed MCH handbook in Kenya as a booklet, and then it has been transformed into the digital MCH handbook. Give me next one. So those cloud-based EMR, electronic medical record system for MCH handbook is really successful in Kenya. Give me next one. Because the introduction of those new technology is not so hard. Actually, it's quite easy because our African friends are very eager to learn about that, even in the community level. And give me next one. Also, mother side is also eager to use also those digital MCH handbook. At the end, those real-time data tracking is available in Africa, in Kenya, because those electronic records is really transferred to the central government, and then they can design using real-time data to strengthen their healthcare system, especially maternal services. Okay, give me next one, because it's really know about which services are available now in one of the dispensaries. That's why the team goes to the weak, or health facilities, the strengthens and also give some support and resources, supplies to them. So it means real-time data tracking is very important. At the end, the missing data is getting less and less because of those, putting data into the handbook, having a caution, and then at the end, people have to filling all the forms into the digital, record. That's why it's a really complete services have to be available there. But give me next one. That's why actually, those digitization is really important for the social protection for the vulnerable mothers and promoting, continuum care is through the, also community health workers using also, common database, and also service tracking quality is improved. Yes. So each of the process is really managed and very effective due by the digitization of the handbook. Okay, give me next one. Also, even if now money transfer functions is included, that's why those free maternal services and also we call account system in the healthcare system mother services is available by the mobile phone in the handbook. So it's really people are freely use the service and they get tracked by the mobile phone by unique numbers. Give me this next one. Also now is a digital insurance system is introduced in Kenya using also those mobile phones. And also mobile technology is connecting all other wearable devices and also healthcare machines. So it's a really one small smartphone is really enables the mother to use the healthcare systems free. Also, those information technologies spread by the especially young entrepreneurs in Africa. And like I have, it's a really incubation house and hub has been happened in Nairobi to think about the new technology introduction in Africa. Also some contest and also some kind of matching activity is now flourished. Give me next one. But that's why the importance of the handbook is really is there in Africa, even if in Africa. Or give me next one. Or give me next one. Those also services, it's increased, not only handbook, MCH handbook, the other service is now available in Africa. Okay, give me next one. It's changed the landscape of the healthcare systems. Those opportunity is happening because due to COVID-19 show the many gigantic unsolved challenges in Africa, especially maternal services. One of the best solutions is really digitization of the services. Okay, we have to track the service availability and readiness. Give me next one. Especially people side, the people fear to go to the healthcare facilities during the COVID-19 pandemic. But the good practice has to be shared by the digital communications. Give me next one. Especially those good practice everywhere in the world is shared by the internet. That's why even if local mothers to know about what's happening in the world, those MCH handbook is now becoming from personal tool into the social tool. Okay, give me next one. That's why a lot of opportunities happening to improve the healthcare system in Africa, especially mothers and the children. Give me next one. But those miracle functions is happening due to the digitization of the services, especially maternal services. Not only handbook, but also other, means of the devices. So give me next one. The purpose at the end, give me next one. Because ultimate goal of the digitization of the services is open democracy. First, fair, fun have to be there. At the end, people share the knowledge beyond the countries, beyond the gender. Or give me next one. This enhance voices from the women for the social transformation is one of the solution is digitization of the services. Thank you very much for your attention.
Yes, thank you, Professor Tsukushita. Thank you very much and for taking the time and telling us about how COVID-19 had a direct impact on the women's health and the children's health. And you mentioned the redefinition of the vulnerability, but also you showed us how all the chances of the service with the digital MCH handbook also used when parents have fear to come to the health facility, and also used in rural areas. So I think, thank you so much. And I think you get a big applause from everyone. And then I want to invite Sarawat Boonsuk, Dr. Sarawat Boonsuk. He will present live from Toronto. He is a Deputy General Director of the Ministry of Public Health in Thailand. And in Thailand, I have already met him, and he has taught a lot about how he used the QR codes in the MCH handbook. And I'm very, and also how they make the transformation of the pink book to the digital MCH handbook, COLO. But we will hear all about their way to reach out to the parents during this very difficult period of COVID-19, also those who are not visible. So Dr. Boonsuk, the floor is yours.
Thank you, Dr. Anne. Good morning, distinguished participants, ladies and gentlemen. Today, I would like to give a presentation on the role of the MCH handbook in the COVID-19 era Thailand experience. For my presentations, include about the COVID-19 situations in Thailand and the problem of the maternal and child health during COVID-19, and evolution of MCH handbook in Thailand, including of the digital platform of the Pink Book. And we have the projects for the safe birth for all in the vulnerable group, especially in the remote area. And the last is the challenge and the next forward of the activity in Thailand. The next slide. This slide shows about the world data. It was found that the number of daily cases of the COVID-19 around the world began to decline in August. The total number of COVID-19 patients weekly confirmed on August in this year is about 5.7 million cases, while in Thailand is about near the 15,000. It can be seen is the graph that the trend of the COVID-19 patients in Thailand is still stable. From the data on death case of the COVID-19 in Thailand has a lower mortality rate than the global mortality rate. It's found that the global average mortality rate is was around 0.4 per million people, while the mortality rate in Thailand is 0.3. And the next slide. According to the data from the Bureau of the Health Promotions Department of Health in Thailand, it was found that the total number of mothers infected with the COVID-19 from the last year to the August in this year were around 15 and 1,000 cases. And the data from the July to August in this year found that nearly 400 cases. The next slide. Based on the data of COVID-19 infected among mothers in Thailand, the severity is divided into 4 levels. I think it's the same in other country, but most of them is no symptom in Thailand, and no death case in this year. The next slide. Next slide. Okay, during the early outbreak of COVID-19 in Thailand, there was a significant impact on the access to health services of pregnant women in Thailand. It was found that the healthcare services had personnel problem because many personnel was infected with COVID-19. The number of the staff who was able to work in the service units was decreases. Many hospitals had reduced the number of service users, which was provided only in case of emergency. Many hospitals use the method of the calling and asking for information from the pregnant woman. If the pregnant woman had no abnormal symptom, the appointments was postponed. In addition, many pregnant women was reluctant to go to the hospital due to the fear of COVID-19 infections, causing the number of ANC or antenatal care cases to be greatly reduced in the early stage of the outbreak. At the present, all the hospitals are back to provide normal services. However, educating pregnant women using the MCH handbook cannot be used effectively. Therefore, there is an idea to prepare the MCH handbook in digital format to make it easy to access and modify the necessary information, and also make it in accordance with the pregnant woman situations. The next slide. About the MCH handbook evolutions in year 2019, the Pink Book applications was about the evolutions of the MCH handbook in Thailand. The Thailand began using MCH handbook in year 1985. After 20 years of using the MCH handbook, Thailand has achieved great success in reducing maternal mortality. Before the use of MCH handbook, the maternal mortality rate in Thailand is very high. It's nearly about 40. And after that, the maternal mortality rate was reduced to 11 per 100,000 live births. I think it's the same another country in ASEAN. Thailand has updated surveillance versions of the MCH handbook according to the changing situations and academic information. However, due to the COVID-19 outbreak situations, the accessibility of the pregnant women health services in Thailand has been carefully reduced, leading the Department of Health to develop the MCH handbook in digital format to make the pregnant women more accessible for the format. Previously, they had to pick up the MCH handbook at the Public Health Services unit, but now it can be downloaded in PDF form, the website, mobile phone applications, or the website MCH handbook. The next slide. The next slide. Okay, and the chart of the platform of the Pink Book. The platform of the Pink Book is divided into the three major sections. There are the application user and operating center. In the application section, it is the part that user or mobile or mothers will be able to see and use it. These sections will store the same information as the physical MCH handbook, which is about the health of the mothers and the newborns up to the 6 years old. All information will be sent into the online database. So this can reduce the loss of the MCH handbook while they happened in the past. For the user sections, it's what divided into two main groups, namely the mothers and the service units. The service units will be able to see the detailed information of the pregnant woman at the community level, to the national level, to the reporting system, or the regions of the country. And the Department of Health can directly retrieve the information as well. For the operating center section, it acts as a call center, communicate to the development team and the maintain of the network related server system and both group of users. And the next slide. And the next slide. Okay, the user can access the Pink Book applications by downloading the app in Google Play and App Store. Apart from the application itself, there are also other online services such as providing information to the various social media and providing information directly to the website. We also developed the communications pattern by using that application such as Line applications. Okay, the next slide. The problem and the barrier of the platform of the Pink Book in these periods. The first one is the staff and the pregnant women over the age of the 35 do not have the adequate technological skill, and the data cannot be linked into the institution's previous database. And we require the considerable time to develop and improve the applications. And many people in Thailand in the remote area do not have access to the internet. Okay, the next slide. And the role of the MCS handbook in COVID era in remote area, we change the digital platform into the paper again for especially in the minority group. Okay, the next slide. The project is we call the Safe Birth for All project. The next slide. Okay, the next slide. The projects located in Chiang Mai province, Mae Hong Son province, and Tak province is near Myanmar country. Yeah. The next slide. The next slide. Okay. In this slide, I will show how we drive the use of the Pink Book in this area to be used as a guide for the healthcare worker to empower traditional birth attendants with the information, evaluation of the mother and the child problem, and assessment and the child development. As all traditional birth attendants are literate, they cannot read, write, or speak Thai or English. Consequently, throughout this training, we make use of the picture, demonstrations, and the healthcare worker who are able to converse with the traditional birth attendants. The next slide, please. In the picture are the example of the MCS handbook in Thailand, known as the Pink Book. The Department of Health has issued the Pink Book in 3 versions: Thai versions, Burmese versions, and English version. However, the productions of those 3 versions is not enough for some area, especially in the area with many ethnic groups and a different language, which are more than the 10 languages. Since the people in the mountains, near the coast border, still use the local language that are the specific to the certain group. There is no written language, only spoken language. Thus, the normal use of the MCH handbook cannot be used in those areas. Okay. The next slide. How to die about the policy in the area? Apart from the health education, we supply health services around 2,000 delivery kits, each of which include a scale to weight infants, a plastic sheet, a bandage, sterile gauze, soap, and a razor blade, and umbilical cord tie. In the situations of the COVID endemic, the project supply around 20,000 home use COVID-19 rapid test kit and the self-study guideline for the pregnant woman to the traditional birth attendant and the healthcare staff. We were trained to use the kit. Okay, the next slide. About the result, we divided this result in the individual result and the national level result. The result in at the individual level found that nearly 1,000 skilled birth attendants were trained in the program that update the knowledge and how to evaluate maternal healthcare and the service by the MCS board through local hospital. During the COVID-19 pandemic, around 200 traditional birth attendants were trained by provide maternal health care, and around 1,000 traditional birth attendants were registered and officially recognized by the Department of Health. And we have to train by the healthcare worker. Is like the training on the trainer, and we provide around 20,000 sets of the ATK to provide the pregnant women in these situations. The result about the national, the next slide. Okay. For the national level result, at the national level, found that the project involved and engaged the policy maker at the ministry, department, and MCS board at the national level, and we try to promote and advocate to the national level, especially Minister of the Public Health and Director General of the Department of Health, to support about the project in sustainability in the future. Okay, the next slide. Challenge and the next forward. The first is we will continue the development of the healthcare worker and the traditional birth attendant in remote area. The second is we will increase the access of vulnerable community to public health services. And the last is we will provide that MCS handbook or the pink book in the appropriate language for the ethnic group. In this project, we learned about digital platform cannot to perform in some area, but we try to promote about MCH handbook to another area in Thailand. The next slide. I would like to share about the Safe Birth for All project in my video for the short time. Please see in the video.
Share sound first.
At the start. Okay.
Just wait a few minutes.
Yeah.
2 seconds.
This is the remote area. It's difficult to access the ANC clinic. Okay. Okay. So sorry, the video is cannot work. You can save and see in the later. Okay. Thank you so much for your attention. And I think is our project is can learn in some country because of the we have the digital platform and we have the paper platform. Okay, the video is cancelled. Okay.
บ้านหนูอยู่จอร์ซีเดอร์ค่ะเดินทางจากบ้านไปแม่สายเรียนนี่ประมาณ90 ถึง 100 กิโลถ้าออกจากบ้านนี่6 โมงใช่ไหมค่ะถ้าทางดีหน่อยนี้จะมาถึงแม่สายเรียนนี่ประมาณบ่าย 2 บ่าย 3นะคะแต่ทางยาวนี้มาถึงแม่สายเรียนก็ประมาณ6 โมงก็เบรกรถมาแล้วก็เบรกลูกเดินเท้าค่ะแล้วข้ามน้ำไปด้วยหัวใจลูกเต้นปกติดีนะ เพราะกลัวว่าถ้าคลอดที่บ้านนี้จะลำบากแล้วก็ยากค่ะไม่มีหมอตามเจอะไรก็เลยมารอคลอดที่แม่สะเรียน
พดุงครรภ์โบราณเนี่ยเป็นกลุ่มคนที่สำคัญนะคะเพราะว่าเขาเชื่อมโยงชุมชนหญิงตั้งครรภ์กับบุคลากรสาธารณสุขจุดเริ่มต้นของพดุงครรภ์โบราณมันเกิดมาจากไหนคือมันเกิดจากว่าเขาอยู่ห่างไกลเขาไม่สามารถที่จะเข้ามารับบริการทำคลอดกับบุคลากรสาธารณสุขซึ่งเป็นเป้าหมายของเราคือหญิงตั้งครรภ์ทุกคนต้องได้รับการทำคลอดจากเจ้าที่สาธารณสุขที่เชี่ยวชาญจะเกิดรอดปลอดภัยแต่ในพื้นที่มันอยู่ห่างไกลแบบนี้เขาช่วยเหลือกันก่อนนะคะเริ่มต้นของพดุงครรภ์โบราณเนี่ยด้วยความที่ห่างไกลอาจจะมีแม่ของตัวเองนะคะบางคนมีผู้ชายด้วยนะคะผู้ชายก็คือตัดสายสะดือการทำคลอดของเขาคือการตัดสายสะดือนะคะพอตัดสายสะดือเสร็จมันก็จะมีคนในหมู่บ้านเนี่ยมีคนหนึ่งที่อาจจะเป็นทั้งแม่ทั้งสามีนะคะหรือเป็นพ่อหมอค่ะก็ช่วยกันเกิดสกิลเกิดอะไรขึ้นนะคะเจ้าที่เราก็เห็นความสำคัญเพื่อปิดแก็บปุดช่องว่างเราก็เอาเชิงวิชาการเข้ามาการดูแลเรื่องแม่และเด็กเข้ามาเพราะฉะนั้นณตอนนี้เนี่ยในสถานการณ์ของประเทศไทยใน3จังหวัดเนี่ยก็ถือว่าพดบเนี่ยได้รับการฝึกนะคะได้รับการอบรมค่ะแล้วก็มีการฟื้นฟูความรู้
Thank you for your attention. Beyond all the digitalization, we never leave someone behind. Thank you.
Thank you. I can't unmute myself, so therefore it took some time. Thank you so much, Dr. Boonsuk. And thank you also for the nice video. I think it says more than a lot of words. And I think you had some nice points you stressed about using the digital function, but also the paper one, and how difficult it is with all the languages and people who can't read. So thank you so much. But because of the time, we switch to the last presenter. My dear friend Agni Bando. It is after midnight in Japan, so it's very, very late for you. Ms. Bando is Secretary General of the International Committee of the Maternal Child Health Handbook. And I work a lot of years with her. And she has a lot of experience with a little baby handbook for parents who have got a premature baby, or with a handbook especially for parents who have got a child with Down syndrome. And she will share her experience today with the specialized MCS handbook in Japan. And may I invite you to give your presentation?
Yes.
The floor is yours.
Thank you very much. Dear Dr. Anneke, thank you very much. Nice introductions. Dear everyone, my name is Akemi Bando, Japanese. I am Secretary General of the International Committee on the Maternal Child Health Handbook. I would like to inform my sincere gratitude to all of your cooperation for success of this conference, and also provided this nice and honorable opportunity to share the experience about Little Baby Handbook in Japan. There are many various situations babies are born at any countries. Some of them are low birth weight, difficult delivery, sickness, and others. The family need a specialized handbook to use it with common MCH handbook. Next, thank you, please. Okay, keep this one. And yes. Under 2,500 gram birth weight baby are around 9.4%, and under 1,500 gram babies are around 0.7% on 2019 statistic in Japan. The family circles asked to make little baby handbook to their prefectures because some part of the common MCH handbook contents are not useful. So the families, especially mothers, have mental stress to use common MCH handbook. So the little baby handbook contents are considered fully and carefully to support the family. Next, please. There are 47 prefectures in Japan. 8 prefecture red covers made Little Baby Handbook from 2018 to 2021 already, and more 26 prefectures are making Little Baby Handbook in 2022. So total 34 of 47 prefectures will begin to distribute Little Baby Handbook from 2023 to under 1,500 gram baby family, and if the family hope to receive it even under 2,500 gram. Next, please. Object to make Little Baby Handbook. The family, especially mothers, are stung with remorse so much because they deliver the little baby, and the family feels unsure strongly. Therefore, families receive Little Baby Handbook after delivery at neonatal intensive care unit. Who are the members to make contents of Little Baby Handbook? Prefecture office who has responsibility maternal child health, representative of NICU doctors, nurse, midwife, public health nurses, representative of the families and expert. The prefectures made a special committee to consider the contents to discuss for near or over half year and understand each other very well and make support network. It is helpful even after finished to make Little Baby Handbook. Next, please. The important concept and the contents do not compare to other common children's development, provides knowledge about little baby, right progress of small step and each development physically and mentally. Kind message from family who have experience for some years already. It is very important to relieve new families' loneliness. Kind message from doctors, nurse, midwife, and public health nurse. It is very important to inform protection by society to the families. Right progress of medical record in and after NICU. Information of various service content, contact address, telephone contents. Why we need a Little Baby Handbook? Only one MCH handbook cannot cover all various families. The families need a specialized handbook with suitable information for each situation, and they use it with common MCH handbook together. Family need observing point to accept their children's situations. Family needs a special social network support from medical, public health, social welfare, and community. Next, please. There are some handbooks to specialize each situation. Public office issue 1, like Little Baby Handbook, and private organization issue 1, 2. Private organization issue note for twin. Some of local government buy and distribute to the family when pregnant women receive MCH handbook as free of charge, or family can buy by themselves at other area. Next, please. Thank you. There are many back to. Okay, thank you. There's many information and knowledge on each term of the progress of pregnancy and how to take care of twin, and also more details medical record. Next, please. Next, please. Yeah, thank you. Public interest in Incorporated Foundation Japan Down Syndrome Society make this book. Some of the local government get and distribute to the family who take care Down syndrome baby. Naturally, family can get directly too. Next, please. Prefecture or private organization issue handbook for children who need medical care at home. For example, provides oxygen always, which includes information, knowledge, message from family who have experience already. Next, please. There is a basic common MCH handbook. And also there are specialized handbook for each situations. It is like tree. Basic trunk is a regular MCH handbook, and each branch means each specialized handbook. So families receive basic and specialized handbook with social and community support by the books, workers, and system. This is one of method to realize no one left behind and goodness support for family, I think always. Indonesia's Ministry of Health and the Taiwan Ministry of Health issue Little Baby Handbook after the 11th International Conference on MCH Handbook at Bangkok. There are 7 language versions of our basic Little Baby Handbook. When you are interested about a Little Baby Handbook, please contact the International Committee on the MCH Handbook. We would like to share the foreign language version Little Baby Handbook URL. I thank you so much again, your attention. Thanks.
Thank you so much, Akemi Bando, for your very nice presentation about the important concepts and content of the Little Baby Handbook, and why we need these special books, and the very nice design of the tree. I think, yeah, we can remember it very well. Thank you so much. Now I will ask Farah Shroff. She's professor of the Department of Family Practice and the School of Population and Public Health in the University of British Columbia, Faculty of Medicine in Canada. It's to give a wrap up of the last 3 presentations and the lessons learned and maybe some reflections you can give. May I ask you to give your reflections?
Thank you very much, Dr. Kessler. It's just a delight to be here. I'm actually calling in from Costa Rica, so it's just a delight to be here. I'm thoroughly enjoying this gathering. I would like to express my gratitude to Dr. Shafi for the invitation and all the organizing, and for all of you who've done these presentations, and really from a much wider perspective, for all of you who devote your professional life to working in maternal and child health. This is an area, particularly during the pandemic, which we cannot forget, and which so many of you have pointed out has become worse. That issues that occurred prior to the pandemic were only exacerbated and worsened during the pandemic. Many of you have pointed out some of the issues related to the social determinants of maternal health, issues related to income distribution that lead to poverty, which lead to extremely difficult maternal and infant health outcomes, and issues related to social status inequities. We know that issues of money and power during the pandemic, as many of you have pointed out, have become even worse. And these are the kinds of challenges which we continue to face in global maternal and child health around the world. We have tragically, as one of our presenters talked about, seen issues related to violence against women, hunger, and other things. But the good thing is that we're all here with a strong focus on health equity, a strong focus with the knowledge that when we lift up mothers, we lift up the world. And I really, really wish to express my gratitude to all the members of this human family who have gathered for the MNCH handbook to talk about these important issues. We heard about Thailand. I was so happy to hear that Thailand's maternal mortality rate has really improved, and that even during the pandemic, there were some times when there were no maternal deaths. That brought joy to my heart. I love being in Thailand, and I love working in Thailand. And the video that you showed was really uplifting too. But it showed us also that people in the rural areas are still having huge challenges accessing care. Having to go 100 kilometers to access care is really quite difficult. Waking up at 6 o'clock in the morning and arriving at 6 p.m. is really tough for a lot of people. And yet there's a commitment to doing it, both from the patient side as well as the supplier side. So that was really uplifting. And hearing about Japan and all the ways in which your tree of the MNCH handbook, you've got this idea that one size does not fit all. So you've got a solid tree with many, many branches for Down syndrome children, twins, other things. It's also amazing to see how having a good standard manual that can be used around the world is really helpful. And this is thanks to all the hard work of so many people, starting from Nakamura Sensei in Japan to all of you around the world who have worked on this for many years. I want to talk a little bit about the presentation from our colleague, Dr. Tomohiko, who talked about technology interventions and how helpful those are. And for those of us who work in global health, we know that technology interventions are often celebrated as the solution to many problems. And Tomohiko-san also did talk about that in his presentation. He talked about M-Pesa in Kenya and how helpful M-Pesa has been in Kenya, and how the digitization of many health aspects brings about a greater chance for democracy. And I have just published a paper with some colleagues from around the world, which talks very much about these similar issues. So I'd like to share a little bit of what we thought about in this exact same regard. Our study is called the COVID Catalyst Study, and we've just published one part of it, which was based on interviews that we did with experts in Egypt, Sudan, India, Canada, the US, and around the world. And one of the recommendations that comes out of our health policy action study was to continue to promote digital health technologies for the improvement of women's health services. That's both telemedicine as well as telecounseling. We often, even today, I think we often forget to talk about the mental health aspects of maternal health. And so having access to digital technologies for telecounseling and for the ability of people who, again, are in rural areas or who have great childcare responsibilities and cannot leave home, this makes a huge difference. And we heard this in our study from around the world, that the burgeoning of telemedicine and telecounseling is making a very positive impact. And yet, I feel like we would be remiss as people who work in this field if we didn't talk about some of the challenges related to technology. And we do in our paper talk about some of the challenges related to technology. So I'll now just enumerate a few of them, because I feel like sometimes in our field, we leap headlong into thinking that there's the potential for democratization of the world with technology. And yet there are also some challenges which are anti-democratic. There's a potential, and those potentials have been realized all over the world, for too much technology to create surveillance. And we know that governments and corporations and large social media organizations are surveying us all. And the more that we use forms of digital technology, the more that we are being surveilled. We know that this can lead to many human rights abuses. So I think it's always important to think about that. Digital technology also has impacts on our own mental and physical health. We know that during the pandemic, digital technologies resulted in even more screen addiction. and we've seen this all around the world. Youth particularly have developed screen addictions. Even us adults have, because we've all been sitting in front of a screen, just like we are right now. There's a lot of positives to having technology, and it's always worth, in my opinion, looking at what some of those challenges are. We've got musculoskeletal challenges, our wrist, our necks, all of these kinds of things, and eye health. We rarely talk about that. So I just wanted to raise a little bit of that, just in the spirit of trying to have a precautionary principle when we talk about some of these issues. The other thing that our study, the COVID Catalyst study, talked about, which I think is very much in line with Tomohiko-san's presentation, is that we must not recreate the world which existed prior to the pandemic. This world was an unequal world. It was not a world in which women's health and maternal health flourished. We must seize this opportunity that we have right now of potential apertures for change, potential openings for change. The pandemic showed us that anything can change. We didn't know this before. We've gone as a globe to many conferences to talk about things like climate injustice and how we're going to solve problems of climate injustice. And prior to the pandemic, we thought it was never possible for planes to stop flying. But as soon as the pandemic happened, what did we see? We saw that planes stopped. We saw that many things changed, and they changed quickly. People saw the sky in polluted cities all over the world. We know now that we can change. And those of us who work in maternal and child health know that we need big changes. We need structural changes if we're really going to take care of the mothers of the world. We know that we need to address issues related to patriarchy. We know we need to address issues related to social status inequities of people who are indigenous heritage, of people who are migrants, of people who are lesbian, gay, bisexual, transgendered. We know that we need to address these equity issues if we're really going to make a difference to maternal and child health. And this, my friends, is our opportunity. This pandemic moment is our opportunity to catalyze change. We will rarely see another opportunity like this in our lifetimes. So I urge all of us to really, really not try to go back to the times of the past. We cannot afford that. We must take this moment to really lift everything up, from the social determinants of health to the kinds of things that we've been talking about today, to the clinical determinants of health. And the last thing I want to say is one of the things we didn't talk about very much related to maternal and child health is family planning. Family planning is still a very challenged area around the world. And one method of family planning, which I really feel gets very, very little publicity, is symptothermal method. This is a form of family planning which is absolutely available, well, poorly available, but affordable and accessible. Once people learn how to use this method, it's a method that uses cervical mucus checking, temperature, basal body temperature, and cervical os changes. It's something that was invented by Cherokee women and Bantu women from Kenya and other parts of Africa. It's an ancient, women-centered, low technology form of birth control, as well as conception and fertility encouragement. This is a completely natural and no side effect form of family planning. Unfortunately, it takes about 6 months to learn how to do it. And it's right now cloistered in particular religious institutions, which don't really like to spread it out very much. But I have a paper or two on this topic and would be very happy to talk about it with anybody. It's one of the things that I feel needs to spread out more to the world. But beyond that, I want to say one last plug for midwives. A lot of you have talked about midwives. I believe that midwives, in terms of the clinical determinants of maternal health, are going to help us solve many of the problems around the world, because midwives often come from the communities they serve. They're willing to live in rural areas. They are able to provide care for the 85%-ish of mothers who have a normal, healthy childbirth. And so we need to really uplift and support midwives in order for them to support and lift up mothers. And finally, I just want to say that when we support the health of mothers, it is a very sacred calling to support the nurturers of the world. Those who are mothers, and I'm one, and many of us in this Zoom room are mothers, I know, provide love. And there's really nothing more important in the world than love. And so when we lovingly support mothers, we improve the world in which we live. So I'd like to say thank you very much to all of you for this beautiful handbook that you have created. I am new to your family of professionals, and I would love to get to know more of you and to collaborate with you. I'll just quickly put in a plug for my organization, the one that I founded called Maternal and Infant Health Canada. We provide free webinars, something like this one, to people around the world. And I encourage you to find me on Twitter or LinkedIn, and I'll get you information on that. Thank you so much. And thank you so much to all of you for the work that you're doing.
Thank you to you, Farah Shof, for
Thank you.
your fantastic summary and your reflections, but also your own experiences with your COVID Cadillac study and the call for change. I think you are quite right. We have to catalyze the change. I think there's a lot to do. So thank you so much. And I think we had a very interesting contribution on additional features and additions to the MCH handbook. And I want to thank you, Professor Sukeshita and Dr. Bonsuk and Mrs. Bando for their contributions. And I think a big applause for you. It was very nice. And now we are moving on to Kelvin, also midnight, after midnight. And he will present the Toronto Declaration. So Kelvin, please, to you, the floor.
Thank you very much, Dr. Anke Kessler. Yes, Dr. Shafi, go ahead.
Yes. Thank you, Dr. My friend Ann Kessler, for your wonderful sharing the session, important session we learned from Thailand, Japan, and my friend Dr. Farah from Harvard. I really appreciate the summary, is amazing. I would like to now switch gear towards the end. It's very sad. It was very exciting last 2 days. We are almost close to the end. But when something starts, there should be some end. But we should have some memory. We should have some record in this era to make change. That's why our group, in collaboration of International Committee, every year, like every other years, end of the conference, we create a declaration, the commitment, the roadmap for next how we proceed. That we did. I am so glad our team, led by Agofaya and Dr. Ware, Dr. Wala, and Dr. Hanna, they co-lead this process, collecting the information, all the presenters, all the stakeholders, and the created draft version. Among that, we discuss and we debate, and we find out a final draft to present to you. I would like to give the floor, Kelvin, to briefly, for the sake of interest, but for viewer, I'm telling you that we have this posted already in the website. If anything you think we need to address, we will be happy to address in our final revision after this convention. And this email is there. You just send us email. Dr. Kelvin, go ahead.
Thank you very much, Dr. Shafi. It's my pleasure to share the Toronto Declaration. So I will just be giving you the highlights of the Toronto Declaration because it's still a work in progress. And as Dr. Shafi have already mentioned earlier, we are still welcoming your comments, suggestions in order to finalize the Toronto Declaration. So basically what the Toronto Declaration wants to state is that we wish to highlight that there are 650 global leaders, policymakers, healthcare professionals, academicians, and other stakeholders from 61 countries who registered and territories, along with global organization representatives from several international NGOs, as well. In addition, The Toronto Declaration highlights the definition of what the MCH Handbook is, being a home-based health record and a comprehensive information tool supporting women throughout pregnancy, delivery, and postnatal period, along with the first few years of their children's lives. So it emphasizes the continuum of care. In addition, there are other modalities other than the paper or book-bound MCH Handbook, such as the digital MCH Handbook, in further improving the compliance and accessibility of healthcare. Also, as presented earlier by our colleague from Japan, special MCH Handbook editions were developed to be tailored to tailor specific needs and conditions, such as low birth weight, children with developmental disorders, etc., in order that no one is left behind, as the main agenda of the Sustainable Development Goals. And here, the Toronto Declaration further highlights that the MCH Handbook integrates equity, diversity, and inclusion principles into the healthcare. The MCH Handbook assures a holistic approach to healthcare services, and the digitalization of the MCH Handbook supporting establishing a population database to enhance social accountability toward healthcare education, research and service activities, and facilitate knowledge translation. And then finally, another is the sustainability of the MCH Handbook program, which demands multi-sectoral, multi-level, and diversified approaches, and the sense of ownership in the implementing country. And then finally, the MCH Handbook being a global standard of self-care that is aligned with the 5 core goals to achieve the universal health care coverage. The Toronto Declaration emphasizes the innovative, equitable, and sustainable development of maternal, neonatal, child, and adolescent health by integrating the MCH Handbook as a standard self-care tool. And thus, we are all committed to the MCH Handbook concept to ensure that in the future, every woman and child is visible. So we hope that the very broad presentation that I have made earlier is in tune to the theme of this conference. And we, as I mentioned, you are all welcome to send your comments and suggestions to further finalize this. Thank you very much.
Thank you. Thank you very much, Calvin. We have a website. I hope our viewer will see. I ask Dr. Sandas, Dr. Nida to put in the chat box our website link so people can easily go and see how it look like and how exciting it is. You can bring take-home message with this, with your office and colleagues. You can share that the way we can survive and sustain. And now is a critical moment. I would like to present before we go to next level to introduce our international president to declare the next conference. I would like to share our participant from 61 countries enrolled, and we conducted survey we call pre-conference survey, and we found very interesting result, and as I'm very proud of. Our intention, as you know, the conference objective of this conference to advocate social cohesion through equitable, holistic maternal child care around the world, to promote implementation handbook, and to support the underprivileged families, including refugees, migrants, and ethnic people. So that's our interest. And the 13th international conference held in Canada, where we have all sorts of experience. We have a minority, we have indigenous, we have all sorts of diversities exist. So how we can start it to boost this process? I would like to show Canadian, our colleagues and our policymaker, researcher, that how the world is doing, evidence is there, and let's share our ideas. So having said that, I would like to move to the conference, pre-conference survey with 246 people joined the pre-conference service. I'm so amazed, thank all of the people. And we found that a majority people that age ranges 30 to 40 is the majority, more than 50%, and the 50 plus, maybe another is another 49 or 40%. And interestingly, most of the participant is the female. And so we could imagine how we desperately need to, men should come forward to help support this initiative. Is a family matter, is not one person matter, is a family, our matter. And very interesting and very good news that most of the people, they have prior knowledge about the handbook, but they don't have a chance to join the conference, and which I'm very happy about it as a conference chair. And on behalf of my group, that 87% people are new attendee. It means we reach out the people, those who never have a chance to join the conference because of many reasons. But COVID, I think, is one of the advantage. It brought us together by media, even though we should have go somewhere and make a huge crowd, but now we're making with the distance, and proudly we're making. And most importantly, that impressed me, and I'm proud that participant profile is not only one single doctor or nurses or somebody else, is an undergrad student, graduate student, postgrad student, physician, nurses, and all sorts of diversity, GO, NGO, official policymaker is there. It means for sustainability, participation is necessary, partnership is necessary, collaboration is necessary. COVID gave us a two important lessons: collaboration and partnership or adoption. These things very much aligned with this finding. And how did participants learn about the handbook? We try to convince them how they know about the program. Majority of people through the LinkedIn, through the professional network, through the Facebook page, especially mostly LinkedIn and professional networking works very well, which is very much important for our future connectivity with you and all. So I think our next conference, the committee will pay attention to reach out these people. And finally, I would like to conclude. So we found a 4 pillar, very clear, distinct pillar. So people is now looking at. So that's we will summarize in our conference proceeding. The one is the education. People want to know about maternal child health and maternal handbook. People want to get connected with network building, platform building. We learned a lot of things, platform building, how it works. And people want to know how a MCS handbook develop, expand, and so on. And they want to stay connected to more update. That's why International Committee are very much aware. Every year or every alternate year, we provide this conference experience to share the knowledge, idea exchange, so that we can learn from each other experiences, because we know together we are stronger. We are here to learn from each other experience, challenges, barrier, how to overcome this situation. That is very much aligned with our plan, why we plan like this way, to share diversity. You can see about 40 plus paper is presented, and 12 or 10 or 11 electronic poster present is there, 10 I guess. And then 50 plus presentation from 14 countries, delegates, and also participant by 61 per country is huge involvement, huge learning opportunity. And I would like to thank my team to get this happen, and also collaboration from Professor Nakamura and the International Committee to smoothly run these things. So without further delay, I will go to my closing remarks, more detail. I would like to go to thank you note after Professor Nakamura declare our next convention, where it will be. And now I switch the microphone to the Professor Nakamura.
Yeah, thank you very much. In the end of the today's conference, and before I would like to mention about the next conference, so I would like to have some my personal comment for this very meaningful and memorial 2 days conference. And I could meet many old friends and new friends. So because Dr. Shafi said, so this is a very new 87% or yeah, so very new participants are very welcome to this international conference on MCH handbook. And I'm very happy to meet these new friends and learn together with new friends. And especially I would like to mention about report. Report also from many countries. All the report are very impressive to me. But so especially I'm very glad the report from Nigeria and Dr. Ogechi and Akaronu, and so sees the starting point of the MCH handbook development. So you are very welcome to this presentation, and because we international committee also have so many members have similar experience. So at the beginning, all the health professional is first trial. In the first trial, we make some mistakes, we make errors, but so after that we have successful these outcomes. And I remember nearly 30 years ago, I also have a similar experience in the rural province in Indonesia. So I remember these things. And for in this time, so I think for not only for Nigeria, as a country also, if you would like to make a plan to develop MCH handbook, please contact the International Committee on MCH handbook. So we will make a support. But support, we don't have so big money, but we have knowledge and technology. That's why we can give us our knowledge and experience of such a technical support. We can do any country who would like to make a MCH handbook. And yeah. And in this time, we are very happy to have a very wonderful 13th International Conference on Maternal and Child Health Handbook in Toronto. And in this opportunity, I'd like to say again the excellent efforts of the organizing committees in Toronto, and chaired by Dr. Shafi Bouillons and all of you. So I'd like to thank you very much. And the next conference, International Committee on MCH Handbook board member discussed last week, and so we would like to decide to recommend Philippines in 2024. Yeah, and I think so. We would like to keep such energy we get such a big energy from Toronto, and we'd like to bring such energy to Philippines. And so 2 years later, we'd like to meet again in Philippines. And please, please, Harbin-san, please say so. I'd like to hand over to you. Okay, please.
I think the video will play for now, Sensei, and then thank you.
Every day, the Philippines does more than wait. putting together new adventures. And experiences for you to try. We're making our sites better for you to see. Cooking up new dishes for you to taste. And preparing cultural discoveries for you to feel. And we're not stopping. Because we know that you deserve more. We can't wait to welcome you.
Okay, thank you very much for the I'm a bit teary-eyed because this is after working for quite some time for the MCH Handbook. It is a pleasure for me to host, no? I am very grateful for the International Committee on MCH Handbook for allowing me, allowing our country to host next in 2 years' time. And we do hope that we will be able to continue the same energy, the same product, the same energy, the same, how should I say, drive that the Toronto team have initiated from this year and then hopefully onwards. We're very, very grateful. And from tomorrow on, our team in the Philippines will start planning for the 2024 or the 14th International Conference on MCH Handbook. Maraming salamat po. Thank you very much. You are all welcome in 2 years' time.
Thank you, Kelvin. And we are very thrilled and excited to join Philippines. We just really amazed that the Corona is behind us now almost. We can move on. Now is the final part. As you can see, we are well ahead of the schedule, 10-15 minutes. I want to acknowledge before I conclude. And I would like to say thank you, Nakamura Sensei, for giving me the chance to chair this 13th International Conference on Maternal Child Handbook in Toronto. And it's never been happened without your direct guidance and cooperation and my team. I really respect your kindness and cooperation. The International Committee, each and everyone, Mama Ware, and my friend Sarawat, my friend Augustine, my friend Akimi Bando, and I miss Dr. Dean Hoy in Vietnam, and others. Can you go that? Dr. Yoko, Dr. Lourdes, Sugishita Sensei, Dr. NK Kelvin, and Grace Alka from Cameroon, and other our associate members and future leaders. I really thanks all my colleagues, but before that, I would like to acknowledge Her Imperial Highness and Crown Princess Akishino, Japan, for her presence and wishes and always be with us to promote Handbook, and her office, good office, to support us and to collaborate with us. Nothing could be possible without the leadership of the Dalhousie School of Public Health, University of Toronto, our colleagues, especially our dean, our colleagues here. And I'm very ever grateful this opportunity to host this in this our hometown, Toronto. I acknowledge Professor Steny Brown for his leadership and support to any international activities, cooperation, and so on. To strengthen the health system in the world, he's very visionary. I thank my colleagues and friends, Dr. Peter Singer, Special Advisor to the WHO, Peter Singer, and our friend and WHO, one of the key person for universal health coverage, Dr. Naoko Yamamoto, who make the opening speech. I congratulate her excellent deliberation and thankful to my friend Dr. Satya from Iran as a UNEP representative. And I acknowledge the UNICEF, our friend Dr. Annie, and also finally, not the last, the least is Mr. Sakoma from JICA. When I talk about the JICA, I become emotional. But you may think that 30th International Conference is happening, is here and today, and we did this today. For coming to this point, I have to work for the last 22 years and started with the JICA and to build the MCH handbook, MCH institution. That's why I met Nakamura Sensei through the JICA friend, Dr. Takeku Yamada. We have still communication is, you can say, a lot of energy I spent, and I still ready to spend my energy to develop maternal child health in the world, strengthen their health capacity in every level, in all community in the world. That's why last 22 years, Nakamura Sensei gave me the chance, and I did the doctorate degree, maybe ever in this world, maternal child health and PhD scholar. So I'm very privileged, and I'm very grateful to Japanese government, Japanese people, and my friends. Thank you very much, Sensei, to giving me the opportunity to come to this point today. It's not only today or 2 days, it's not only 5 years, it's not 10 years, it's not 20 years, it's 22 years I work on this. Can you imagine? From 5 country to the 60 country. You can imagine the development happened under Nakamura Sensei's leadership is amazing. So I'm thrilled that I'm part of this global movement. But nothing could be happen without 3 things I would like to share today. One is the gratefulness, another is the cooperation, another is the togetherness. The 3 things are always giving me my mind. So no matter how great we are, we need to acknowledge other people, how great they are listening to you, they are supporting you. So I thank all my colleagues, my family, my friends, my students around the world to prepare me to come to this point today. Thank you so much. Another thing, I was a student of Nakamura Sensei in the department called International Cooperation. And even I don't know, as a physician, what does it mean 22 years ago? And look at where I am now. So I'm telling this story because it really means a lot. Some mentorship is important. Who can cooperate, collaborate, not giving only just, you have to do this and that. No, who lead by example, that is Professor Nakamura Sensei. And that's what I try to share my students, so how to do things. And you see, the 13th International Conference actually achieved a lot. We learn a lot together than we give. How? Is collaboration. Toronto is a diverse, Toronto is a hub of diversity. The people is local, but it's global. People is global, but local. You see the committee of International Handbook host committee, can you show all the brilliant, bright, young professionals I work with every day, and they are actually global. They're not local. This is the only host committee ever. We just absolutely global committee in the local level. So that means a lot. I cannot express enough thank that in my word, how much I'm proud of you. All of you made work so hard last 10 months to make it happen today. Dr. Wala, Sandat, Rabi, Mastari, Stefan, Shemima, and Angela, Tasdeed, Saida, Agafaya. So maybe I don't need to explain her name because all the world people know her name. And now Yashida, Mithila, Yasmin, Mahima, Rizwan, Fayaz, Kaumin, and Nabila, Muhammad, Iman, and Nadia Fatima, and other many those due to the space limitation, we just try to just give it at all. So I really thank you. You make me so proud, and world is listening, world is watching how much young people can do if they're together, if they have a good mentor, the guidance. I don't know how good I am, but I try to work with you, learn from you, so that we can move forward. That is my greatest strength, to have a young professionals with me to do something challenging, which is possible to do, because impossible itself says I am possible, and you made it. So that's why I would like to thank all the participants from around the world, 60 countries. Without you, actually no meaning to hold this conference. So to disseminate our intention, to disseminate our objective, and to work togetherness, and how to do it, we need you. We need your attitude to collaborate with each other in your country, within the country, outside the country, within your office, outside your office, so that we are there. As Nakamura Sensei already mentioned, that if you need any assistance, we are not a funding organization. We are collaborative knowledge translating organization. We give you the technological idea how you can do better. So imagine 22 years ago when I start to develop Bangladesh handbook, there is not a single literature out there. Now hundreds of literature, even my group presented 47 literature. You see, that is the strength for now. That's happened only the network we established under the leadership of Professor Nakamura Sensei. And that is the key. Together, and we can achieve more. That's why I said, I talk about gratefulness, I talk about cooperation, I talk about togetherness. Now, I would like to conclude that this conference, actually, the support, the collaboration we receive is very inspiring. Whatever I ask, like from WHO, from the Dalai Lama, everybody came forward to support us. I thank all each one to this front. Special thanks to our dean, and thanks to our faculty members of Dalai Lama Clinical Public Health and Global Health Center. I would like to thanks again all the country presenter. Those 2 days they present the country presenter for their great presentation. And I would like to say, ladies and gentlemen, our participants, those who are abroad, once again, let's give everybody as a big applause to congratulate yourself, not only me or my team, everybody. We made it together. We came to this point together, and together we are stronger. We should be always moving forward. Thank you very much. Hope to see you in Philippines. I think now official record is finished. We have one more thing I forgot, is a survey. Friends, I would like to ask Sandar to show the survey, how it looked like and how they can submit, even in the chat box. And if you submit your survey, then you will have a certificate. Also, Dr. Sandas will show you the certificate. Within 2 to 3 weeks, we'll mail you your certificate. Sandas, go ahead.
Thank you, Dr. Shafi. These are just final steps that we want all the registrants to do. Please let me share my screen. So the link I shared in the chat, you can view this survey. And through that, we want to know your original name. So the name that you want on your certificates, please mention it over here. Then to which email address you want your certificates to be emailed to, please mention over here. Then a few questions are very important for us, because at the end of the day, this is an academic conference and we want to do a research post the conference. The questions are, how satisfied were you with the topics presented at the conference? In your opinion, what was the most informative part of the conference? So you can select one or many. We would also like to know if you would like to participate in future global events of the MCH handbook. If you're interested to volunteer with us, if you are, then the email that you provided, we will send you some future events. If you would like to receive future communications from the MCH handbook, for example, newsletter and future events, if you click yes, we will send the newsletter and future events information to the email that you provide. In this question, how would you rank? You can click on this box and you'll see 1, 2, and 3, and you can rank it according to 1 to 4. For 1, we have, which is much less expected according to your expectations, and through that till number 4. For question number 9, we also want to know about what was your overall expectation from the conference, and you can select any of the bars. Here are the percentage that is selected, and here are the numbers. 1 means it is much less expected, and number 5 means greatly exceed expectations. Then we want to know how satisfied you were with the virtual experience. And if you want to provide any suggestions for future events, which we will forward to the Indonesian team so that they can make the following changes. And finally, please submit that so that we can send you the certificate in 2 to 3 weeks. Now, I would like to show you how the certificates might look like. So here, your name will appear. And if you were a part of the participation and you had the presentations, you will receive a certificate of recognition. And because you were a part of this conference, the 2-day conference, you will also receive a certificate of appreciation. And if you have any further questions for the team, please kindly email us on the email provided on the website. Thank you.
So thank you so much. One more thing, fact check. I think we develop a questionnaire, how much knowledge you gain. Still, we can do this survey. Or 1 minute is there. The poll. Yes, I think I also forget. I was so excited, so I forgot actually key thing. The knowledge check. So I think we just click there, friends and colleagues. Please try to answer the questions, and we have to see how useful our time was to spend with you. It's not a final thing. Just try to memorize and guess and just put it there. We'll see how much you learn from the conference. Thank you. Oh, it's getting better. Yeah. Excellent. Excellent. We have 112 now. Sorry, we missed 30, 40 people, but it's okay. Please answer and try your best. There is no pass fail. You will get certificate. This is the maybe exam you don't have to worry. So Agafa, how many minutes we have to wait? Maybe our schedule is 2:25. Maybe yeah, we have another 4 minutes. So, but 3 minutes is better. So give them time. Yeah, I want to do exactly finished at the scheduled time, 12:25, and today August 25. OT. 43. We can just review. How many we received? Yeah, 64. Yeah, 62% is okay. I think we should continue 1 more minute. 23. Okay, we stop. Okay, okay. Then thank you very much. We stop, and we also thank all again, and please stay safe and healthy. And we can see the poll result. Okay. Okay, this is the result. Only health record of the mother, delivered pregnancy, health record of the mother. First one. First one.
First one in Japan.
Yeah. 1998 first in Japan.
In Japan, so 1998 48 is a
Correct answer.
correct answer. Yeah.
And second one?
Yeah. Second one is also health record of the mothers during pregnancy, deliveries, and
Third one.
yeah. Third one
Third
is
one.
a
Is
correct,
the correct
answer.
answer. And next.
Yeah. Next is yeah.
Concept is
the same, but the content is tailored, different. Yeah, this is
Yeah. So thank you very much. It means everybody now understood that what the handbook started from Japan, flourishing around the world. And no matter what, we are not making the copy of the content, but we copy the concept, but we create our own to support our own cultural diversity. So we respect culturally respectful services, and this is exactly all you know already. So friends and colleagues, thank you very much for your cooperation. We understand we should move forward. We have enough knowledge, and now we need to act. We need to do our job, our part. Thank you so much again, and please stay safe and healthy, and we will defeat the COVID and we'll move forward. Thank you. Bye. Bye-bye. We can stop recording.
Bye-bye.
Stop recording.
Okay.
Thank you. Thank you. Thank you, Sensei.
Yeah.
Yeah. Okay. Okay.
Thank you.
Okay. Thank you.